innovation and bring people together to understand, I guess, innovation, technology, entrepreneurship, bringing VCs, entrepreneurs, healthcare systems all together, start having discussions around the future of healthcare. So we're delighted to be here at the Business Design Centre in London for our first visit. We've been very accommodating. And of course, all our sponsors and our startups and people who've come to really support us in our mission. Of course, we live in difficult times during the pandemic. We've just seen the new variant, the Omicron variant coming through. So people are quite rightly concerned about the future of healthcare and also how we manage these kind of events. This is a hybrid event. So we have a live audience here of quite a few hundred people who are going to be milling around the centre. Also a virtual attendance out there. Hopefully we can stream live and you can watch what's going on. And that's the model of the future. It has to be a hybrid. It has to be a way that we bring people together. We give people the option of flexibility. So they can sit at their own homes, watch it at their own time, so they can all kind of interact with these live conferences. And that will happen in 2022 and beyond. So what we've got to this kind of next 2 days is kind of a number of amazing speakers and panel sessions to think about the problems we're trying to solve and the challenges we face in healthcare, not just in the UK, but around the world. We've got participants here, even from as far as Brazil during the pandemic, who've come to show their kind of platforms, their ideas, and share ideas with the network that we've created here through Giant. Giant itself has a community of almost 300,000 people across the globe who all connect through our live TV station and our episodes that we do on Giant TV, through our newsletters across the world, and also our live events this year. Well, our first event this year was in April, the very first day that we're allowed to come out of the pandemic and be live in Liverpool. And Liverpool Council greatly accommodated us at the Liverpool Centre. We also had a 5-day exhibition of 5 conferences in 5 cities in April, which was hugely successful, bringing the European community together to understand where health is heading towards. We had conferences in Barcelona, in Paris, in Stockholm, in Berlin, and Liverpool over 5 days, with thousands of people registered around Europe to, again, share the experiences of this common goal of improving healthcare and outcomes for the people around the world. So without further ado, I think we should make a start on our first session, and it's a great privilege for me to kind of present our first kind of moderator our session, Shane Tickle, who is a great friend of mine and really being at the forefront of understanding what healthcare challenges might face for the future and being a real partner to us at Giant. So Shane, thank you for that. I'll hand over to you to do the panel session.
Thank you, Shafi. And good morning, everybody, and welcome. And if perhaps I could ask my colleagues to come up, and Shafi, if you'd be so kind as to stay with us this first session. We're also going to be joined in true hybrid fashion by one of our guests who's going to dial in remotely. Now, for those of you who have watched the advertised session, sadly, I am not Roy Lilly, who was asked to chair this session, but I do work with Roy a lot. We do a lot of health chats over the last 5 or 6 years. And in fact, Shafi, you've been one of our great guests. But Roy can't be with us this morning, so he's kindly asked me to step in. So what I'm going to do is introduce the session, introduce our panel, and we'll get on with a discussion that's going to take about 30 minutes. And if there's any audience guests, we'd love to have you involved and bring your questions. So the question and the session is about how do we make the best use of good technology and reward it fairly? And does the current system work really well? My name's Shane Tickle. Several of my roles, I work with Roy at the Institute of Health and Social Care as a strategic advisor. I run 2 health tech companies, and I've been in the electronic patient record space for 25 years. I also am a vice chair of Tech UK, where we have around 400 tech companies in the UK coalescing, and I work with a lot of SMEs, mentoring and helping some of their CEOs. Will, perhaps I could ask you if you'd be so kind as to introduce yourself, your current role and your previous experiences.
Thank you, Shane, and it's lovely to be here. My name is Will Smart. I'm Global Director for External Relations at Daedalus Group. We're one of the largest health tech companies globally. In that role, I work with external analyst companies and also with our Global Advisory Board around strategic developments in healthcare. I've been doing this for the last couple of years. Before that, I was CIO for Health and Care in England, working on the digital program, working with ministers and leading the digital program across England. And Before that, I had a proper job where I was CIO at the Royal Free in London, which feels like a long time ago. So it's a pleasure to be here, and I look forward to the discussion.
Thank you very much, Will, and it's a delight to have you here because you've got so many perspectives. If I may, I'd like to come to Adam Thomas, the CIO at Dudley. Adam, would you be so kind? We had a great chat about a year ago, and it was really inspirational. And I'm really excited that you're here to join us today, effectively speaking on behalf of the service and ICS. Would you be so kind as to introduce yourself?
Yes, thank you, Shane. It's a pleasure to be here, and I only wish that I could be there in person. My name's Adam Thomas. I'm a Chief Information Officer at a large acute and community provider trust in the Black Country, West Midlands. And I also represent digital data and technology on our integrated care system board.
Adam, thanks ever so much. And Shafi needs no introduction, but Shafi, I'm delighted you could be with us because you work with so many tech companies, and it's interesting. We've got so many startups here at the conference over the next couple of days, as you've said, people as far away from Brazil. So I'm really looking forward to your perspectives as well, if I may. So if I may, I'm going to throw the question out. And Adam, it might be really interesting to start with you, if I may. Does you think the current system of how we buy and procure technology of any kind to do with health and care, do you think it works currently? And if not, have you any thoughts about how you think it could work better for us?
Well, it's a great starting point. So let's kick off with some ideas. We've got to go back to the beginning of healthcare. Healthcare is about the triple aim of population health, of experience of care, and cost containment per capita. And I think that using that model over the years has been the right focus for healthcare. But the current models, I think, around financing digital to support better healthcare perhaps don't get the best for what the population needs. But what I mean by that is sometimes it focuses on point solutions and short-termism rather than considering how we build better platforms for integrating care and seeing the bigger picture and how things can improve over time. So really how we drive societal value and economic value from our investments. I think probably the key bit right now is planning, and uncertainty, like in any business, creates an environment where it's very, very difficult to plan and very, very difficult to put strategies into action. And I think that's perhaps one of the key elements of the current environment that makes it challenging. To move that forward, I think there's probably a requirement to your second part of the question to build models that are blended and that are hybrid, that reward the delivery of digital healthcare in different ways. And so some of that might be around certainty of block contracting and driving productivity and efficiency. Some of that might be incentivizing true innovation in areas of unmet need or where there is inequality.
And thank you, Adam. And with that, there is some inherent risk, but also the success of digital projects, which people say about, research tells us about 70% of intended values from projects isn't realized. And one of those areas is transformation, actually making sure that whatever it is we try and do. Will, could I ask you to speak to that?
Speaking as somebody who worked in the centre, I think our funding models are completely broken. And one of the challenges, I think, is we've got ourselves in a position where almost organizations are waiting for funding to arrive from the centre before they will actually invest. And we've got ourselves in a perverse cycle of local organizations not saying digital investment is a core part of investment they need to make to manage their organizations better. So I'm hoping that the who pays for what development begins to change that paradigm. So I think we need to rethink the funding flows. First of all, I think one area, and I think the centre has done some great work, and I think, for all of the criticism of the GDE as a programme, they have begun to develop or prove that the NHS can do tech. One of the agenda items we had there was to try and help the service build the business case for investment in core digital infrastructure. by actually measuring the impact it had on the frontline service. And I think one of the challenges that I've had throughout my career with every finance director I've ever worked with is that when I go with the business case that says, it's fine, CFO, I'm about to give you a 10% return on this stunning investment that we're about to make. And once he stopped laughing, he says, well, we're not going to see any cash out of this at all. That's a fantasy, but I can understand why we'd want to invest it. And I think one of the biggest challenges that I think local services and industry really need to be working on is measuring the value of what we're doing, because until we can demonstrate that value, I struggle to see how we can get the kinds of investments that we need. And then finally, Shane, because I'm talking too much as always, we also need to move the dial in terms of expectations around level of investment. We spend around 2% in the UK health. I was in Spain recently. They were very impressed. We spent as much as 2% on technology, but if we ignore Spain, let's make the case that we're massively underinvesting in digital services, and we need to be making the case that that needs to be closer to 5 or 10%, at least in the short term, to begin to drive the fundamental infrastructures that we require in order to really drive the transformation.
I mean, I, for one, have been supporting that the investment in healthcare isn't just, I see and hear it spoken so much about as a cost, but it's an investment. And you know, so much, the great Professor Hans Rosling, who sadly is no longer with us, but he did some studies over 20 years and looked back over 200 years across the world at cities, at countries. And what he tracked was those cities and countries that invested in health first always became wealthy, and it was in that order. It wasn't the other way around. And so to me, health isn't a cost, it's an investment. Shafi, if I could turn the conversation a little bit, you work with some incredible, technology companies. Now, not all technologies, when it comes out, is going to be successful. And some of those companies have backers, some of them take risk, but also the potential users take risk as well. And I wonder, how difficult, the companies that you're meeting, do you come across them, how difficult is it for them to get off the ground, get their first few customers, and especially if there isn't a guaranteed return, because that's the hard bit, right? Getting a return, as we've said, Will said, is you can map that and you can try and explain it. But actually with new technologies, that's just so hard.
Yeah, so let me go back to a little bit and answer the question that you asked earlier around that whole funding flow. And I think let's zoom out a bit. Let's just zoom out and say, what's that bigger picture look like, rather than go into detail. If you look at healthcare at the moment, we need to move away from acute specialty and secondary care to primary care to social care. The pandemic has shown us we need to care about humans and their well-being, supporting well-being, supporting the mental health, and supporting their kind of preventing illness. So this whole sick care to well care is that kind of well-documented kind of statement. That's where healthcare is heading towards. So all the funding technology needs to understand that principle of maintaining people's well-being, empowering people, based around technology, maybe the solution. So that's the bigger piece. I sit in the NHS Assembly trying to understand that a bit better. What does it look like? Now we're seeing the ICS, etc., being set up, maybe as a portal or a pivotal point where we might be able to do that. So that's the first to understand about where that money needs to be translated to. Second thing is about the startups coming in. So look, we meet some amazing startups with great ideas who've just going to change the world as we speak. Of course, they have barriers. The first thing, of course, for startups when they come through is to show some income generation. The VCs want to show some return on investment, but of course, they won't have any return on investment because there's no kind of income generation or contracts in place to show that growth. That's the problem. How do they get within the healthcare system to show some growth, to be able to attract funders in, whether it's VCs or private equity or even family offices, to pay that initial money? Also, it's that process. What does it look like, the whole infrastructure of funding, whether it's seed funding or angel investment or indeed Series A, B, and C? Where does that pathway go? We know most founders will fail, sadly, but failure is good. It teaches a lot of things about healthcare and how to survive and then learn from those mistakes. What we've tried to do at Giant, for example, our own event, is to support nurture some of these companies, to support them through a difficult system to understand. The landscape's more tricky. There's many stakeholders involved. In the NHS, for example, we have accelerators, entrepreneur programs, innovation centers. We have the HSNs, all vying, competing to bring these people in to then get them into the healthcare system. And NHS NHS Digital, I mean, it goes on. Where do you start, where do you finish? I'd like to see a more seamless way of bringing people in, supporting them. And one thing that we've done here, which was later today, is launch the Digital Therapeutic Ventures. We want digital therapeutics to come in. We've set up a company around that to support people from outside to navigate the pitfalls of the NHS and understand where they can get that from. So the landscape's a bit tricky, but it's about support, it's about network. Hopefully we provided some of that over the last few years, trying to make it easier for people to understand that difficult landscape in the NHS. So I'll leave it there, but that gives you a few snippets of my understanding where we are.
That's superb, Shabby. Thank you very much indeed. Adam, I'm going to come back to you. I remember when we spoke about a year ago, you talked about the Dudley pound, because you look across the economy, and now we have the formations across England of the ICSs. But I think the Dudley pound, or it could be the Scottish pound or the Welsh pound, or for our international clients, it could be anywhere. But you've spoken to me in the past about how you see that investment, not just in technology, but in the well-being of, as Shafi said, of the well-being, the prediction and the prevention. Can you talk to that?
Yeah, absolutely. I think you've got to take that economic view of your local population, and that's exactly what we've just heard. And I think the key to that is opening up different conversations. So we did a piece of work and audited and explored the wider values around a year's worth of video consultations and online consultations through COVID. We generated an enormous amount, about 290 kilos of carbon dioxide recovery. We freed up about 80,000 car park spaces. We took about 2 million miles off the road with patients travelling. We took about 136,000 hours of waiting in a waiting room away from patients in terms of experience. And when we put all of that together, it allows us to have different conversations with our partners and multi-agency partners and say, look, working with the council, how could we fund things that work better? How do we address some of the digital inequalities? How do we support that conversation linking to highway maintenance and roadworks and all of the rest of it? Now, there, obviously, the initiation of a conversation that thinks of the wider value of the impact of a virtual care setting or using digital in a different way. And they're not, of course, directly mapped to pounds and pence, but they represent how the local economy is functioning, how conversations can move forward and think differently. And I think that's what the power of those is. And some of you will have noticed this week that a company has bought a bit of virtual real estate for virtual tours in the retail sector at $2 million or equivalent to $2 million. And that just shows you that the conversation is moving on to genuinely think about our physical estates for delivering health and care and services to the population, and a virtual one. And I think that's where we need to have some of the conversations, is that we need to look at how we recover cost or we recover spend in our local populations, and we consider what that means and make it personal. You know, the Dudley dollar, if you like, we'll call it that, and that gives a real focus on how we can work together more effectively.
Thank you. Will, if I could come to you, because you've talked about the level of investment that we've underinvested. I mean, we underinvest in health, but in the digital part of it, actually 2% is quite high compared to previous decades. But do you think, you know, talking about, as Adam's given that example, where so many parts of the locality are invested, do you think that we might be able to change this, or do you think we're just too embedded in, there's an annual budget, the NHS gets this much, social care gets this much? How do you see the future?
I think I go from deeply depressed to sometimes feeling there might be a route through, because I think it is a really difficult conundrum. And I think, to what Shafi said, you know, I spent most of my career in the NHS in the acute sector, and we like big buildings with cool machines with flashing lights that do really clever things. But actually, at the point at which a patient arrives in the acute hospital, almost that's failure demand, because we've not dealt with the demand far enough away from the acute sector. And it's, you know, I think the statistic, certainly before the pandemic, was 70% of acute beds have got patients with multiple long-term conditions who actually, had they been better managed in the community, didn't need to take up those beds. So The good news is I don't think any system globally has got this right yet, so we shouldn't be too depressed. On the other hand, I fear that we need to take a radical rethink of the whole system. And, you know, when Beveridge in the 1940s wrote the Beveridge Report, it wasn't just about health, it was about education, it was about welfare, it was about housing. You know, perhaps the NHS needs to think about, we take out 70% of our acute capacity, or let's be generous, 50% of our acute capacity, invest in social care or invest in housing or invest in other parts of the system that actually can prevent that, that demand flowing into the sector. And fundamentally, I think, reorganize the investment in our digital healthcare system. I'm not sure I'm not sure whether the NHS can do that on its own, and I actually think it's the entrepreneurs that Shafi is working with that will work outside the system, that will use the system with the innovations that they've got, that can actually reimagine how care can be delivered virtually and outside of acute care, that I suspect will be the levers that will transform how the system operates. So I'm looking to Shafi to sort the problem out, because I've failed over the years.
Shafi, I'm going to give you a magic wand. You can have whatever you like.
No pressure. Yeah.
How do you make this better? What does ideal look like? What's good look like?
That's a really good question. I think, yeah, we shouldn't beat ourselves too hard, because no one's solved all the problems. I think the other thing to think about, so one of the things I often talk about is global solutions. And the pandemic has shown us that we're a global community. Lots of good ideas out there. People have really solved some of those issues. How do we, as the NHS in the UK, for example, learn from China, from India, from the Middle East, other parts of the world who've got other challenges, but try and solve them, and who might have leapfrogged us already in some ways? And I'll give you a few examples. Look at Africa. We talk about Africa, and you know, a lot of lower middle income countries who may struggle to do certain things with the population, but they have mobile money. They had that for years. They leapfrogged us many years ago, thinking, how can we do better? And so, for example, I worked with the Abu Dhabi government as the advisor for digital transformation for a year. And look at that, for example, a small country of 3.5 million people or so, who then decided to invest over 4 billion into health tech innovation by creating the Hub 71, supported by the State Sovereign Fund. And then they brought startups in. They connected all their hospitals through a central healthcare information exchange called Malafi. Happened just a few months ago. So they've got all the data, real-time metrics of what the population is doing, how they're behaving. So we can then go to think about how to move care into the community better, how to solve the problem. So they've done that already at pace. And they're bringing people in to say, here we are. We'll open up our doors in the hospitals and clinics. Fast-track innovation. If you've got a good idea, we'll implement it straight away, validate it for you. It's back to the question of how do you validate fast? So government's taking initiatives, saying we can do this better, and learning from those experiences. And so those are the kind of examples. We just go out there and say, okay, what can we learn from other industries, maybe, other health partnerships, other governments, other healthcare sectors, and bring the best of learning. They share that on a global level. I'd love to see more interactivity learning. And we could solve the problems of the pandemic a long time ago if we'd listened to what other people are doing across South Korea or China or Japan or Singapore, for example. So I just think we need to listen more, get out there and take the best of what we see and apply it to the NHS. Why not?
Well, I'm with you 100%. And I spent probably a fifth of my time in a week working with organizations and trying to transfer knowledge, because sometimes actually we're reluctant to listen to our next door neighbor who's already fixed some things. And I think that to me is probably the single biggest opportunity we've all got, which is let's learn from the past, see where we are for the future. And I think a lot of us have a really good idea of what we want to do. We want to predict, we want to prevent. But we have almost a natural instinct, which is when we hear something for the first time, is to reject it because it couldn't possibly be a clever thing. And psychology tells us you've got to hear it 5 times before you eventually kind of, you know, own the thing locally. So where do we go next with this? I have a couple of thoughts. The NHS, I have to say, has really stepped up. I've really enjoyed NHSX opening up its doors, opening up to strategy, and actually saying, here's the direction we want to go to. That's been backed with, in just the last couple of months, about £750 million here in England for NHS health and social care organisations to actually bid for. On top of that, if I go back, Shafi, to what you were saying before about investors, people who are venture backers. I believe the British Bank might have some kind of a role to play here. I've been in this sector for 25 years. I've had more successes than failures, but some of my failures have literally cost my company millions of pounds. And it's a really difficult one to then go back to the board or back to your investors and backers and say, hey, we didn't quite get it right this time, but we'll get it right next time because we've learned so much. It's really hard for them, right? So I don't know. I'm going to open up this now. I'm not going in particular order. Who'd like to take this question? Is there another way that we can help when there's something new coming along? It might be that there's a risk, but we all believe in it. And I think you need champions. We all believe in it, but that we can limit the risk or we can be open about the risk. Who'd like to take that one?
Well, maybe I'm happy to have a start. So we're having conversations with a number of our customers around what strategic partnerships look like. And I think it's very easy to have the conversation around success. It's actually very difficult to have the conversation around risk and actually around how risk is going to be shared between the various parties. And, my experience is, both when I worked in the NHS and now when I'm talking to NHS organisations, the NHS requires certainty of outcome because that's the way you don't get hauled in front of the Secretary of State for Health, or if you're an NHSX, don't end up in front of the Treasury. And of course, organisations like mine don't like to take all of the risk. So I think we need to have a more mature discussion around the risk of what we're doing. I think we need to have a more mature conversation around what partnership looks like. And actually, in my more cynical moments, which coming from Northern Ireland, I have quite a lot of, we're tech companies. We are populated with people whose only job is to do tech. We don't need the NHS how to do tech well. We need the NHS to tell us how to do care well and where we can have maximum impact. So I think we need to again change that conversation. And finally, if implementing an EPR is the answer to digital transformation, I'm not actually sure what the question is, because the EPR will not transform your organization. So we need to have different discussions around actually what are the transformative investments that digital can make that truly will move the dial around productivity or around outcomes or whatever it is, without continually thinking we need to do more of what we've done in the past because we understand that. And I think that means we need SMEs. We need to find ways to get SMEs into our organizations. And we need to accept that sometimes things won't work, and that's fine.
Thanks, Will. Anyone else got some? Adam, Shafi, do you want to have a go? Happy
to share a few thoughts, Adam's, I think, there as well. I think, look, a risk is important to mitigate. It's about how do you mitigate risk with technology and innovation. If you look at the way we've conducted ourselves for decades to bring in new ideas, it's about the randomized controlled trials. It's been the gold standard for years. If you look at that whole story, and I'm an academic, it takes 7 years for an idea to go through the whole process and to be then translated into clinical practice. In 7 years, the world has moved 200 years in these days and age. You're obsolete. So first of all, clinical trials, research validation needs to be at pace, understanding n equals 1 rather than n equals 1,000, and to be able to do that very fast and understand the risk involved of doing that and stopping as required. So that whole concept of research needs to change. Secondly, I think it's about, when we talk about startups and ideas, we don't throw technology at a problem. We try to understand the problem first and foremost, what challenge do we have, and then go back saying what technologies might be able to support some of these ideas to be able to create some solutions. And very often I've seen just through technology and throw at a problem is not the right way. And the other thing that people fail to do is not be laser focused on a problem. You're trying to solve one problem at a time almost. You can't solve the whole world. So when you do a little startup, we have an idea is what specific problem are you trying to solve and how you can solve that. And sometimes that gets missed. A lot of people are trying to design new ways of working. And with that kind of way of thinking, let's take an example. The NHS recovery programs. I'm just sitting on the London elective recovery program by NHS London, headed by the medical director. And we've been talking the last few months around what are those ideas, blue sky thinking. How can we redesign surgery for the future to stop waiting lists, to get patients streamlined to have surgical operations? The 5 million people or more who are waiting currently for either diagnostics and operation. So we've been allowed to think outside the box. And 160 million will be invested in the next 2 months by December, and then over $1 billion by April. So now we've got opportunity. What an opportunity to rethink a model of healthcare. And so those are kind of things now, really incredible opportunities to find these solutions that we need going forward. So they're asking us, what does good look like? And I've been thinking about it for a long time, thinking I'd love to just on a blank piece of paper write down, this is what surgery looks like for 2030, for example. So people are now thinking outside the box slightly, and it's just allowing us to shape those ideas. And hopefully the ICS will be the kind of the pivot for us to move forward.
Fantastic, great stuff. Adam, what do you think?
Yeah, I am at risk of fiercely agreeing with what the fellow panel members have said. For me, there's a big piece around confidence. So confidence of leadership, not just the digital person who might be at the board, but the confidence of the entire leadership of an organisation to grapple with risk. Risk is not binary. And as we've just talked about, actually, the confidence is about formative evaluation of your project. So understanding how well it's doing and the incremental gains and change, rather than have you done a piece of work and it failed or succeeded. And that helps leadership guide things in the right way. And I think COVID did a lot to open that up and open the eyes of people who perhaps were not confident with digital healthcare and innovation investment in that area. So we've got now a real opportunity to change that. As Shafi said, absolutely have to focus on a problem and opportunity statement and say this is where we need to work, but not try and start from a solution. We need to pull towards solving the target. The last point I would say is that we, in doing all of that, we have to recognise that the NHS is actually a massive tech business. It survives and requires digital technology and data to function. And therefore, it is a key asset, the data that we hold, how we use that, to drive better health outcomes, needs to be a focus of our conversations more often. And we need to see those tools as things that can help us change the way healthcare is delivered.
Such wise words, and I fiercely agree with them. I'm going to ask the audience if you've got any burning questions, if you could get ready with them, and perhaps one of our colleagues with a roving mic could go and could go and ask them in a moment. Transformation's a big part, isn't it, in relation to digital technology? I honestly think we underestimate it, and frankly, as digital tech companies, we're kind of steered away for pricing from it because it's often seen by the customers as, oh, that's okay, we'll take care of that. And I just wondered if you've got some views on how we can package in and make sure there's nothing worse as a supplier than putting in a great solution, but it not being properly adopted and people getting the best use out of it. And that's really, really hard to stand back and say, you know, I want to see you get more for your purchase. You any experiences, Will, of how we've done that really well and made sure transformations happen and adoption's gone really well?
I'm probably the last person you want to ask that question to. I have a career littered with failure, which is how you get international jobs. A bit of advice. I don't really have advice. I think the point's well made, and I think it maybe goes back to what Shafi said, that often we end up starting off with a problem that we're trying to solve. We're all very clear about what we're trying to deliver. We then get into the technology part of the project, and suddenly we lose sight of the change we're trying to make, and we become really interested in servers and networks and configuration and all of the stuff that gets technologists excited. So I think it requires singular leadership to kind of focus on the outcome first of all. I think one of the successes that we've had in the NHS maybe over the last 5 years that was maybe driven out of the WACTA review and out of the work that Keith McNeil and I did, which was around beginning to think about the role of clinical leadership in some of this work, thinking about the role of nurse digital leadership. In Royal Berkshire, I was always really interested. They had a chief operational information officer. Too many O's in that, but where actually it's about saying there are different stakeholders and interests that need to be aligned with this project, and actually we need people to step up and to be doing that leadership. And again, I think last point might be, we sometimes fail with transformation because we get distracted too soon. We think we've got to the end of the project and therefore we've done what we need to do. I'm now going to go and start the next thing. And we never spend time embedding or reviewing or refining or working through the next phases to really embed the transformation, to really drive out the benefits. So I think there's something about leadership, and there's also something about not stopping too soon, to keep going and be focused on the objective.
Great, really wise words and a great experience. I can certainly support the leadership piece. And I think what I'd add to that, Will, is maybe we don't actually celebrate and remind ourselves of what we set out to achieve, what we do actually achieve. And I think, Will, you are particularly hard on yourself. But genuinely, do we stop and say, actually, here's what we got out of it? Because often we have unintended positive consequences as well. Shafi, Adam, do you want to come in?
Yeah, just a couple of points to make about the last statement and a few examples. It's about change management. It's not about technology or anything else. It's change management, change behavior. And we've seen healthcare workers generally resistant to change. It's kind of who we are. We're kind of stuck in our ways. And I kind of often talk about the dogma tradition of healthcare, which is kind of ingrained in our DNA. The pandemic has shown us we can change. So more people are innovative, more translations happening. But take an example about 5 or 6 years ago, I was a champion of EHR. You'd be pleased to hear that, Shane. And I was sent to America by Cerner to Kansas. If you've ever been to the Cerner campus, it's enormous. I went to about 3 or 4 hospitals to look at what they were doing, translate paper records to electronic records. This was probably about 6 or 7 years ago. Went to Florida Hospital, which was beautiful. It was a beautiful lake, lovely weather, gorgeous brand new hospital. And they decided one day to turn everything into digital, to go onto Cerner platform. And so everything was connected, the ECG machines, the IT, whatever. When I spoke to the people who are running this, it was really interesting. They said, initially we had these people who are employed by the trust wearing red shirts saying, come to me, call this number, we'll help you transform. So they're constantly there 24 hours a day to help them navigate through changes. So we planned them being there for 3 months just to help support people to ensure they were complying. They were there 3 years later, every day, all right? So it showed that the difficulty in transforming behavior, despite having good technology that will transform people, and that's what we're going to concentrate on. So I think it's the ability to understand people's behavior, change, and make it stick, and make the least digital savvy person in the organization raise their profile to become more cognizant of what that might be for them in the future. That's a challenge for healthcare. I'm sure Will saw many of those things across his entire career, trying to create that change.
Tough one. Have we got any questions from the audience? Yes, we do at the back. If we could pass the mic, thank you very much. If you can introduce yourself and ask your question.
Hi, my name is Pilar. I'm the founder of iExpand. Thank you so much for this interesting chat. I think you're referring to the same issue in adoption. Culture eats technology in adoption for breakfast, lunch, and dinner. In my experience, it's never been any other way. So, like I think in other countries, I'm originally from Spain, I know some hospitals have it. When are we going to have a digital coach in every single hospital in the NHS England? Thank you.
What a fabulous question. Adam, what do you think?
Coming soon, I hope. We're doing a piece of work at the moment, working very closely with our workforce committee, recognising this challenge. So we're trying to create a community of interest, really, where each directorate, each department has an information officer. We'll find the right terminology, but for want of a better term, an information officer. And building that ownership across the organisation we see is absolutely key to addressing some of the problems my fellow panellists have just mentioned. For me, to get some of this right, it's about co-production and co-design from the beginning, and that needs to involve citizens and the population as well, but certainly members of the workforce who are going to take ownership for continually improving and iterating solutions. So I think this is something that's not too far away.
Excellent. Will?
I'm going to be a bit controversial, maybe. I think one of the challenges we have in the NHS is we still other digital and technology. So that sits over with the CIO, and they have their committee that deals with it. And they'll come to the board and get some money, and at some point they'll come back, and it will either be a tremendous success or a dismal failure, but it's done by them, and we can carry on in the board talking about patients and theatres and important things. I think every healthcare organisation needs a digital challenge. I think the digital champion or the digital coach in every NHS organisation needs to be the chief executive, and it needs to be the chief executive that's driving the digital agenda from the top of the organisation down through, rather than kind of having committees and other people that worry about it. I spent last week with the Florence Nightingale Foundation with the digital nursing work that they're doing, the RCN saying every nurse is a digital nurse. That's the culture we need to drive through. So at the point at which the chief executive is the CIO, I think that's the point at which we begin to get to the world you've talked about.
Fabulous. As CEO of mission critical software suppliers for 20 odd years, I try to spend 80% of my time with a client listening. Shafi, as a clinician and trying to adopt technology, what do you think?
Oh, this is a real bugbear of mine, so I could talk a whole hour on this one. Let's go back for a fraction. Do you think medical school, nursing schools are fit for purpose at the moment to create the healthcare workers for it? Of course they're not. They're way behind. Jay, he's at Cambridge, right? Medical student doing his finals in 2 days. So is your curriculum designed around digital? Are you understanding where we are? Nowhere near it. So it's not fit for purpose. So what are we doing going back to stage one? Create the workforce of tomorrow, but today. So with that, I used to be Associate Dean at Barts Medical School. So we run the Barts X program and Imperial run the Imperial X program, bringing innovation, digital health, technology, entrepreneurship into the undergrad curriculum to create those health workers who are going to be designing healthcare of tomorrow. So, and we're the first in the world to do this. I can't believe we're still the first and the only ones in the UK still bring in the curriculum. What about postgrad? Do we invest time in human capital to innovate? So one of the things we don't do in the NHS very well is invest in human people, right? As a consultant for the last kind of 2 decades, no one said to me, Shafi, you're doing great as a cancer surgeon. How do we help you innovate? What can we do to support you during your job plan? Give you a PA to innovate, do new things, new ideas, new pathways. How do we support that? We write about those crude metrics, about outcomes, about how many patients are in clinic, how many operating on, efficiency measures. Actually, what we should be doing is actually, how do we invest in you, the ideas that will change? So I'd love to see the NHS bring innovation to the heart of every job plan for every consultant, every trainee, every nurse, saying, let's empower you to design better. 2 things will happen. You retain staff because they're leaving in their droves. So how do you retain people? And people change over 10, 20, 30 years. They want new, fresh challenges. So the idea is to retain people, to invest in them, their time, their thoughts, and bring digital learning and language of digital into the heart of the organization, which haven't done that yet.
Thank you so much. I always fascinated to speak with such experienced and clever people because you never quite know where the conversation's going to go. It's been absolutely fascinating listening to you all this morning. Can I offer you at least at the last word any final messages? It sounds to me what's come across is partnership, leadership, openness. These are all absolutely intrinsic to taking forward our technologies and getting the best out of them. And yeah, the money's got to come, but actually it sounds like partnership and cooperation, sharing the risks, sharing the planning, sharing the ideas, but importantly, sharing the leadership too. Last word from everybody, please.
So I'd say we need to embed innovation into the heart of every person in the healthcare system and reward them to think differently and think better.
Well,
I think we need to radically rethink what healthcare systems need to look like, because I don't know what the future digital health system will be, but it will be fundamentally different to how it operates today. And I think we need more time spent maybe in the NHS thinking about that future, innovating, but also thinking about what do the new models of care and organizational structures need to look like to do things fundamentally different.
Will, thank you. Adam?
I think it's about people. It's investing in people. It's about investing in education. It's about linking into how we build things with career paths, as others have mentioned. And I think we need to do that at scale, and we need to understand the value of healthcare data and how it might inform that planning and making systems that look different.
Thank you very much. And I think it involves a certain amount of courage too. Look, thank you very much to our audience. Could you please join me in thanking our panel guests this morning for their contribution? Shafi, Will, Adam, thank you very much indeed. And thank you to Giant Health for the opportunity. Hope you have a great couple of days here.
Coming from pharma companies, but also from DTX companies. Let me quickly start with Susanne. Susanne has seen both sides of the world, working for a pharma company for many years, Novartis mainly, and now joining Sidekick Health. Welcome to the panel.
Thank you.
We also have Stefane from Novartis. He is the head of digital solutions for ophthalmology. Welcome to you as well. Then we have Nikos. Nikos is the senior venture architect from Rox Health. Rox Health, it's a company builder. At least that's my way of looking at it. It's a company builder for specific therapeutic areas, and they are working with digital therapeutic companies on behalf of Roche. Welcome, Nikos.
Thanks, Ralph. Hi, everybody.
So then we have Johannes. Johannes is the Associated Director of Digital Health Solutions within Novartis Global. And I'm happy to have you also on this panel to share some insights about how Novartis is looking at digital therapeutics.
Hey, Rolf.
And then I have Klaus, at least sitting virtually next to Johannes. Klaus is the new business development manager and innovation head from Janssen. Welcome, Klaus.
Thank you, Ralph. Thank you.
And last but not least, we have Thomas Goenich. He is also representative for a DTX company. Is the commercial director Germany from Teladoc. But we talk more about Livongo, which is an acquisition of. Ready?
2020. Hi, Ralph.
2020. Okay, last year. Hi, nice to have you on this panel. So how we structured this panel, we have a quick intro statement here of all of us. Then we will have a Q&A session. You audience, you also have a chance here to raise your hands and put out some questions which you want to address here to the panel. Altogether, we have 75 minutes, but I would like to start the discussion now by sharing a few ideas about this topic, more to basically to introduce what we are going to talk about. Let me quickly share my screen. Okay, good. Okay, so the main question is how does pharma make use of DTX solutions, so digital therapeutic solutions? And we will discuss mainly, I guess, four main options a pharma company has. So on the one hand side, they could use those digital tools to support their research. So supporting clinical trials, creating evidence that their existing drugs works. And lots of solutions have been developed in order to support clinical trials, providing real-world data, supporting patient recruitment or engagement or the patient education throughout the clinical trial. So that's potentially one major area where pharma company will engage with DTX. Then we have this option of supporting the existing drugs. We call it the pill plus strategy. So supporting the pill by adherence, by awareness tools, by logbooks, symptom trackings, and reminders. There are already many solutions available. That's an option. Or pharma companies could use the digital therapeutics to replace an existing tool. So to create completely new treatment for a condition which has been served by the pharma companies in the past. So this replace option also exists. Or to create completely new business areas which have not been served in the past. So maybe there are also other options here, but I guess we can discuss those options also later on in the Q&A session. There have been many ways of implementing those strategies executed by pharma companies. We have seen lots of partnership models over the last few years. We have seen lots of accelerators being created by pharma companies, incubators, company builders, you name them. We have seen partnerships being directly closed between pharma company and DTX companies, especially over the last few years. We have seen the growth of venture funds and acquisitions by pharma companies, and lots of digital tools, I would say, in the beginning have been created and developed by pharma companies themselves. So we have seen thousands of digital tools. Maybe we wouldn't call them today digital therapeutics, but over the last few, I would say, months or even a few years, we have seen that more serious digital therapeutics projects have been launched already internally within pharma companies, expressing the growing importance of DTX solutions for pharma companies. So I have already introduced briefly the panelists, which will support me in that discussion. I would now like to hand over to Johannes. Johannes, as I mentioned, is the Associate Director of Digital Health Solutions within Novartis globally. And Johannes, the stage is yours. Please let us know what Novartis globally thinks about DTX solutions.
Sure. Thank you, Ralph. Very good to be with you guys. I'm very excited for this. So as Ralph said, I am part of the Global Digital Health Solutions team in Novartis Pharma. So all our innovative medicines outside of oncology. Our team is sort of centrally responsible for identifying digital and data-based solutions that can sort of scale across our priority markets and our priority therapeutic areas, with sort of the aim to support patients as well as HCPs and healthcare systems, so payers. So really sort of taking that broader here with you guys today in my opening statement. Within the team, I am leading all efforts related to virtual care, hybrid care delivery, but then also sort of database treatment interventions and everything related to that. So with that lens, I think I'm very excited to be here today because for me, sort of digital therapeutics are really going to be sort of a central piece of how care will be delivered in the future for patients. And I think that's directly aligned with the trend that everybody has been talking about forever, but is now sort of finally coming to fruition, which is the sort of consumerization of healthcare and that sort of completely different expectations that healthcare users and consumers, which are the patients, are going to have on this. So sense and broader definition of digital therapeutics that Ralph has also just shown, I think they really have the potential to reshape the roles in healthcare so that we are sort of starting to move towards a situation where patients and payers, healthcare systems, will have a significantly higher impact on treatment decisions than they do have currently. And that is all based on the data and the insights that are gathered and generated by these DTX solutions. And I think we as a big pharma company therefore need to have a very clear view on how we want to position ourselves strategically in that moving ecosystem and in what role we want to play in that. And so I think what we need to answer is basically three questions. There's the why we're doing this, the what should we be doing, and the how can we do this. And I just want to very quickly go through all three of them, have some early thought starters, and then very interested to see what other people actually share on the panel as well. So on the why, I think pharma companies really enjoy trust from patients and from HCPs when it comes to the treatment of the disease and the really detailed understanding that we have of underlying conditions and the diseases themselves. So I think we should use that trust and understanding to help patients, particularly that are suffering from a certain disease, to help them achieve the best possible outcomes they can and provide opportunities to the broader ecosystem to achieve these results in the most effective, including cost-effective way. And that, I think, is a positioning that pharma can take. That is, I think, a natural role for us to play, and is also a role where it sort of ensures our relevance going forward, even when sort of that traditional pharma ecosystem an HCP is shifting. And I think that that can be critical, because if the HCP impact and power is starting to be reduced, and that is our natural customer as a big pharma company, then we need to think of new ways of being relevant in that ecosystem. And I think that can really be the positioning that we have. But I think what that also means, and that is important because this is such a fast-moving market and so new, I think we also need to be really focused on what we're doing. So I'm coming from the commercial perspective. So for me, the whole sort of clinical trial aspect is sort of outside of my scope. But when I talk about the commercial setting, I think we really, as a pharma company, have to focus on the therapeutic areas where we have an established role, and sort of be within that, or at least in very close adjacencies to that. So in Ralph's graphic that he showed before, I am most, and think the biggest opportunities lie in the pill plus, and as well in the replacement opportunities there. So what that means, in contrast, I don't see a big opportunity for pharma companies to use DTX to get into new therapeutic areas, or even move sort of along the value chain more into the preventive space. I think that's not a natural role for us, but that's just one man's opinion on this. Then if we move on to the what, I think looking at the what, the key anchor for me is really sort of the patient pain points that are existing in the status quo, and really sort of take them and identify what are the shortcomings, what are the needs of the patient, that we then make sure that anything we develop alone or in partnership is then sort of really having a meaningful impact on patient outcomes. I think, as I said before, we want to focus on specific therapeutic areas, and that sort of also dictates in the individual solution, right? What is some of the things that you can do? I mean, there's some things like, is a disease showing symptoms, or is it asymptomatic, right? Like all of these different things need to be considered in what the solution can actually do. And I don't think there is a one-fit-all solution for all therapeutic areas. So we really sort of need to make sure that this is relevant also from a clinical and medical perspective to the individual solution. And then I think what we need to figure out is really sort of what are the key points in time on a patient's health journey, sort of that we can engage them and then offer meaningful support to facilitate their sort of journey along that health journey. And for me, I think from a pharma perspective, there are three main opportunities for that. So one is improve the speed to the right diagnosis, because there's so many patients that are still sort of suffering today from sometimes even years until figuring out what is really wrong with them, and sort of going between doctors, and then they have symptoms and they don't have symptoms, and just there's this uncertainty around this. And I think by focusing on providing diagnostic tools and providing better access to care, also virtually via telemedicine, I think that's one big area of opportunity where we can play a natural role. The second one is empowering patients so that they receive the best possible treatment. So that means sort of focusing on remote monitoring, remote treatment interventions, and all these kind of things that then facilitate sort of guideline appropriate pathways to the best possible treatment. And then sort of when patients are on that best possible treatment, then really sort of support them to achieve optimal outcomes in that treatment. And that is, I think, very much focused on tailoring and personalizing traditional existing solutions around patient support programs, but then also going much broader into sort of other quality of life elements, may it be mental health or something like that, that we sort of really look at this holistically from a patient perspective. What are sort of the other key determinants for outcomes for these patients? So now that sort of I've laid out that, I think the only remaining question from me right now is the how. And I think there are different pathways for big pharma companies to achieve that. Realistically speaking, I think building these solutions in-house is probably only happening in very rare cases because of the sort of speed of innovation that's happening in the industry, the required capabilities, and also sort of the initial upfront investment and it requires to set this up internally. I think that is going to be very rare cases where we actually do that. So I think the sort of the maturity of things is going to be either partnership or buying solutions. Those are sort of, for me, the two big elements where I think what we're seeing right now, at least across what I can see from the industry, that partnerships is sort of the preferred model because it's sort of the less risky, the more agile way of doing this and leaves you more options, right? And I think that's why it's super exciting today to have all these different perspectives also from DTX here. So partnerships, I think for me, is a great way to sort of start identifying, validating hypotheses, running pilots and stuff like that. But then the question very quickly is going to become, okay, where do we as a big pharma company actually see potential for strategic differentiation to our competitors in a given therapeutic area, and then make very smart decisions around where we see that ability to sort of differentiate ourselves, then really invest in that and own that solution, because I think that is going to be the critical success factor in the future. And we're seeing that in some of the more, let's say, established areas for DTX, like diabetes, etc. already, where some of our competitors are making big moves and acquiring DTX companies for a significant amount of money. So that's sort of my initial overview on thinking, and happy to discuss this further in the panel.
Thank you, Johannes, for this intro. Very structured layout of how Novartis is looking at digital therapeutics. My first question to you would be, I mean, internally, are DTX solutions within Novartis, are they seen more as a threat or as an opportunity? How would you sum this up?
I think definitely as an opportunity. I think the sort of the nature of our treatments and the diseases that we focus on the most part, and I mean there's some examples where that is not true, but I think for the vast majority, we are not really yet at a point where there's going to be a realistic case for full replacement by a digital therapeutic. So actually what this, I think, offers us is a huge opportunity to say, hey, we can improve patient outcomes significantly, and we can really sort of, if we figure this out right and we do this combination of classical pill-based treatment with a digital therapeutic, I think that has a potential to transform patient lives. So for us, it's a big opportunity.
Okay, so happy to also discuss that with the rest of the panelists then later on. But I would now like to hand over to Susanne. Susanne, I would say you are maybe not a special case, but you are special, at least here in this panel, as you have seen both sides and has worked for many years within Novartis as well, and have developed digital strategies and implemented them. Yeah, and now you moved on to the other side, to a company which entirely focuses on developing digital therapeutics. And I would describe Sidekick Health, which is the company you are now working on, in more as a factory that produces on an ongoing basis digital tools to support different therapeutic areas. So maybe you can explain that much better than I'm able to do that. Susanne, it's all yours.
Yeah, thank you, Ralph. And I take it as something positive if you say I'm special.
Sure.
Maybe I'm a bit of a hybrid, which is very attractive nowadays. But yeah, you're right. So I worked 19 years for Novartis Pharma in multiple commercial leadership roles. And then for the last 5 years before I joined Sidekick Health, I was working with a cross-functional team for the global respiratory franchise to build a personalized and connected ecosystem for respiratory patients. And I'm still very proud of the fact that we have been a team pioneering the first wide-scale launch of an inhaled asthma drug together with a digital companion from Propeller Health, so a sensor and an app that could be attached to the inhaler. And the drug plus the companion is approved by EMA, so it can be prescribed by physicians in Europe, which is, I think, a good go-to-market model to really scale the digital solutions. And in my role, I work with different startup companies and have seen also different business models. We tried different things to really bring digital health solutions to patients. And I realized also a bit in my role that if you want to make a fast difference and really accelerate things, it's good to be on the startup side. And now I'm working for Sidekick Health to build and establish long-term relationships with pharma partners. So I also have some insights now in other pharma companies than Novartis. A bit about Sidekick. Sidekick Health is, as you mentioned, a digital therapeutic company founded in 2014 by 2 physicians, actually. So it's not technology-driven, it's more data and research-driven. This already a vision to improve the health of humanity. And I know it sounds like a big ambition, and we have this idea to really bring healthcare into everyone's home and everyday's life, a bit like Microsoft many, many years back, with the vision to bring computers to everyone's home. Our Sidekick platform combines an evidence-based clinical approach with behavioral economics and gamification. So our chief product officer comes actually from the gaming industry to make sure we really have a setup that is very engaging to all the users. It also includes a care management portal for remote monitoring and communication with coaches and within communities. So real coaches, not just artificial coaches. We develop digital therapeutics for multiple lifestyle-related diseases that can support also patients with multi-chronic diseases. So it's a very holistic 360-degree approach, if you want to say so. One of the key success factors of our programs is the high level of personalization, where a digital footprint for every user is generated to provide the best possible support at every time. And that's something I'm really passionate about. And also during my time at Novartis, I realized how difficult it can be to provide individual solutions to patients that serve a very specific need at a very specific time, as all of us are so diverse and different. And I'm actually glad to see that with our Sidekick platform, we have industry-leading retention rates. So even after 4 months of using the programs, we still see more than 80% engagement of the users, which means about 8 to 12 daily interactions, something that we call missions that are completed by the users. And I believe this personalized and behavior-based approach is what is attractive to our pharma partner. So our digital therapeutics do not only add more clinical evidence to their drugs, but definitely empathy, user engagement, and patient empowerment. If you look at the use cases today and tomorrow, I think the partnership models and value will definitely change over time, because if you look outside, the healthcare environment is changing so much. Also, of course, accelerated by the pandemic we are all going through at the moment. And we see more and more really clinical evidence of digital therapeutics with their own mode of action and digital endpoints that make a big difference in medical practice. And I mean, with Stiga as a starting point, but also in other markets, we see more processes and opportunities to get digital therapeutics reimbursed. I think if you look at the partnerships we see today, it's a bit dominated still by digital companions, with the objective to differentiate to other competitive drugs, to increase adherence and retention to medication, which is still a big issue, unfortunately, but also to generate real-world evidence and real in-depth patient insights. And interesting enough, those partnerships are often driven by digital teams, maybe more than business teams, which is also something potentially that I will see changing in the future. The more advanced organizations, I would say like Novartis, see data and digital already as a strategic pillar with a clear role in providing better and more patient-centric solutions. I think patient centricity is a big topic here, and also driving relevant commercial partnerships. At Sidekick, we have partnerships with pharma and with payer. And I also see an increasing interest from both sides to enter as rebate partnerships. So that's also an interesting approach, I believe, that could add additional value. Looking into the future, I think the partnership types will change. And that's maybe if you see the digital companion as Pill Plus linked to your chart at the beginning, Ralph, I also see a strong opportunity in the new business models and really co-developing prescription drug and prescription digital therapeutics with a clear focus on clinical outcomes where data lakes that will be generated also provide opportunities for risk and value-based contracts. I mean, we know that market access is a challenge for medication and new drugs coming to the market. So I see in a combination with a digital therapeutic that could increase the likelihood, but also the market access model. And maybe, who knows, in the future, pharma might select digital therapeutics and partners in that space, like they select a compound for a BD&L deal. So instead of license fees, the revenue is based on royalties and achieved value. I think we see more and more digital therapeutic companies being at JP Morgan, for instance. So there's definitely a big shift happening. Based on my own experience, if I should name maybe 3 key success factors for successful wide-scale digital therapeutic launches, I think, first of all, being really clear on the objective and the value proposition of the partnership, short-term and long-term, and reconfirm that objectives regularly. The second aspect I feel is really important, to be realistic and transparent on the organizational readiness. Everyone who worked on a DTX launch, I think, knows it's a journey with constant learning and strong change management that is needed. Actually, on both sides, right, pharma and the startup companies, the change both parties are going through is different, but I see it now at Sidekick Health, where we have really a high-speed growth of the organization. So you need to manage to further build and strengthen your product, building the organization and building new partnerships with pharma or payers, and everything at the same time. So the company is changing constantly. And that, of course, is also an aspect for our partners, existing partners, to align with and to follow, knowing that they go through their own change management journey at the same time. So I feel having this transparent sharing is really important. And the third aspect, I believe, is also critical, that despite the fact that in the traditional pharma world, new processes have to be established, doing things differently, I think it's good to build on established processes. So not trying to do everything different, and launching a DTX like a drug with a global leadership, cross-functional teams behind it, involving key markets early for the go-to-market strategy and execution, to make sure that at the end of the day, you really get sufficient users to your program so that they can benefit from it. So I would say moving from pill plus to new business models is what I foresee for the landscape of and the value of pharma and digital therapeutic company partnerships. Back to you, Ralph.
Thanks a lot, Susanne. I'm really curious here to get this topic also in the panel later on, and to understand what is now possible within Cyclic Health, what might not have been possible within Novartis framework, developing those DTX solutions. Before we enter into this discussion, let me quickly hand over to Klaus. Klaus, as I mentioned, is developing basically new digital solutions, the business around that for Janssen in Germany. And when we had a chat before this session, he also mentioned the specific and important role of DTX in his view for those rare diseases. So where DTX could play a major role in helping the treatment of patients which have a rare disease, for example. But now I would like to give the floor to you, Klaus, to give us a quick intro on what your thoughts are about DTX.
Yes, thank you, Ralph, for the kind introduction. And first of all, a short disclaimer, I'm addressing my personal views here, not the views of the company, Janssen Germany. For me, digital therapeutics is, first of all, an evidence-based software program to detect and cure medical disorders or diseases, and I think it's very important to have this evidence available for this type of solutions. And as already mentioned before, it can be used independently as a monotherapy or as a partner product to a pharmaceutical product in a combination therapy, and that's, I think, currently the focus where these type of solutions are used, but in the future it will move definitely more into the field of monotherapy. And the overall goal for all solutions, and I think that's crucial, is optimizing patient care and the outcome for the patient. And that's where it all has to start from. When you are developing this type of solutions, I think it has to start from, it was already mentioned, from the patient pathway way and how to address the needs of the patient. That's important as well. So I would say that digital therapeutics definitely open up a new pillar in the healthcare system, not only in Germany but also all over the world. And due to the fact that reimbursement systems are coming up more and more, I think digital therapeutics will be an additional treatment option, and definitely will support value-based healthcare approach, because those solutions are scalable with impact on care, health outcome, and cost, and that's the mainstay for value-based care. And to mention it again, yes, evidence-based therapy is necessary, even if it's a partnering product or whether it's a product that will be used in monotherapy. We all know that even a prolongation of overall survival for metastatic cancer patients has already been shown, and just by using a symptom tracker for this type of patients. And I think that's important, how big the opportunity for those patients is. So as already mentioned by Ralph, digital therapeutics can be used in several parts of the value chain, and as a supporting product for clinical trials or real-world evidence generation. So the patient data gathering in a real-world setting, therefore, digital therapeutics are quite nice, and we are exploring these opportunities because this will definitely lead to a reduction of time to market and being faster at the patient with new products, and all this by reduced costs. So that makes absolutely sense. But the current focus is more in the digital therapeutics. For digital therapeutics, is more in the supporting the efficacy of drugs by creating a favorable environment for the pharmaceutical product, by increasing compliance, by supporting the processes around the medication, or even by better data exchange. So combination therapy for the time being, I would say, is in the focus of many pharmaceutical companies, and digital therapeutics can provide those features that improve outcomes for pharmaceutical products, as already mentioned, in the field of compliance, by setting reminders and changing behaviors of patients around pharmaceutical products. So it can be used as of a pharmaceutical, and a digital therapeutic is key here. Yes, and beyond this, digital therapeutics have an own and independent effect. And in the German healthcare system, when you want to have a DiGA in the German market, you must show that the solution has an independent effect and can be used in monotherapy. And that's a good opportunity, for example, to implement treatment guidelines in the solution beyond the medication, and do this in a cost-efficient way by increasing the quality of care within the patient pathway. So in general, digital therapeutics are opening a field, a new field for value-based healthcare, by setting the scene for better quality, a better outcome, and this all at lower costs. And I think that digital therapeutics in monotherapy can be a new revenue stream for pharmaceutical companies in the future. But that currently we do not see this, that is used very much. So, as Ralph already mentioned, yes, we discussed rare diseases because more and more products coming to the market are orphan drugs for very small and specific patient groups. And here I am firmly convinced that digital therapeutics can offer a lot for these patients, because digital therapeutics can easily be developed even for smaller patient groups in a very cost-efficient way, and open up the healthcare system and democratize it for this type of patients who do not suffer from common diseases like diabetes or heart failure. I think especially in the field of rare diseases, digital therapeutics offer a centric approach, and that's important from my perspective, and that's what I wanted to share. Thank you, and let's discuss it later.
Okay, thank you, Klaus. I mean, if we have time later on, I would like to also discuss this question of what could be done on a country level, yeah, and what must be done on a global level. Yeah, so if we look at partnerships with from between pharma and DTX companies, what should be done on a global and what should be done on the local level. But before we enter into this discussion, let's get Nikos in. Nikos is representing here another pharma company builder, one of the company builders, one must say, from Roche, Rox Health, and they are helping companies to basically to grow in the digital therapeutic areas, especially in Germany. But Nikos, the floor is yours.
Yeah, thank you, Ralph. And I have been following with attention and with what you have been saying. So I'll adapt a little bit to it because I think I would agree to most of what you have said. I tend to side, I think, a bit more with Susanne in believing that DTX also have, a right to play and the potential to also allow us as pharma companies to go into new, business models and to new fields. However, maybe, if we take again your taxonomy, Ralph, you mentioned a second dimension, a temporal dimension might, clarify that, because I think Johannes, yes, pill plus research is what they provide now, where the potential is now, where you see really effects. But in the future, we might end up, also in these other fields. So maybe a little bit to Rox, because I think we are really some sort of an embodiment of, pharma beliefs in DTX. So, like Novartis, like Janssen and others, Roche also has, its own experience with, digital health and digital therapeutics. On your slide, you had the acquisitions of MySugar, also of Flatiron. And of course, there were some learnings from that, right? And I might focus a little bit more on how we enter and how we work with partnerships, because the rest was I think addressed in a very good way already, and we would have time for more discussion. So after this, we work at Rox. We are based in Berlin. We focus mainly on the German market, but of course we also look into other European markets, because as also Klaus was saying, digital solutions have the potential to be scaled also in different markets when they are adapted to the needs of the healthcare system. And so Rox was created basically to further these partnerships, because as I think Johannes was saying, that to have the required capacities in a fast-changing environment is a challenge. But on the other hand, Susanne also mentioned already that partnering with the digital companies also has also benefits towards the inside, right? Towards the pharmaceutical corporation, also in terms of mindset change, because DTX companies, I think, at the moment present us with really creative bandwidth, which we can use really to rethink how healthcare is delivered. And in order to bring that to the market, that's a long way. And I think this is where pharma at the moment can provide the most also benefit to the startups or to the partner companies, because they know these ways, right? You can do this also, but it's quite challenging. And I think when partnering, you can introduce these challenges in a stepwise fashion that makes life a lot easier, when going to the market. And this is basically what we do at Rox. So basically, we work with startups, we work with clinicians, we are a company builder, yes, Ralph, we're also an accelerator, so we partner very early on. So let's say you have an idea and you build a product of this, but we also partner at the stage where you already have a product and want to bring it to the market. And we've seen, with all our corporations, we are existing since early last year, so not that long, but of course, part of our staff has a lot of experience in that field. Has been that basically all the companies, being a seed startup funder all the way to Series C startup, so a company that has already some, let's say, organizational structure, processes established, they all tend to struggle a little bit with these aspects. And this is where so far the feedback has been quite positive, working in sort of a gearbox mode, so they are directly exposed to the pharmaceutical, they are not directly exposed mainly to the healthcare market, but it's moderated by an entity such as us or others. There are also others that do this, is perceived as very, very helpful. And I think that also adds to how payers and how healthcare professionals as well as patients react to it, right? Because oftentimes what we still lack is a familiarization with these tools. There are some indications, of course, where like diabetes, where that has been established, and of course the current pandemic also fueled a lot of experience with part of digital health. But I think there's still a long way to go, and this is what we try to foster, and I think what's also necessary for DTX to succeed, because DIGA and all these things are really good on paper, but if we really look at the numbers, they're not that great, right? And so I think also pharma has still, let's say, not only pharma, but pharma has also maybe a role to play in bringing these solutions to a certain level where they can so to say sustain on their own, live on their own, which we are not there yet, right? So this is basically what I would like to add. The other thing, the only thing I was missing, I think Susanne mentioned it, co-creation is really important for these solutions to succeed. We, as you all, I guess, also do, we co-create these solutions. So we also put the startup, mainly they have been doing this themselves, but we also put them in contact with the different stakeholders. But what I'm missing a bit was also this aspect of open innovation, which is a hard sell also internally, but we tend to lock up our data within our organizations, and for good reasons. There are some competitive interests, but I think we leave a lot of value on the ground, and I think even these partnerships with DTX could be a way to enable. So we are also, open and look for cooperations, not only between, us and startups, but also even, competitors or partners, other pharmaceuticals, to work together. Susanne mentioned also, an setup where payers are also involved, because in my role, so I work with the startups, but I also work with investors. I also work with payers, and, using this as, so to say, common ground, like a DTX as a common ground to enter in such a collaboration has been so far quite successful and fulfilling, I must say. The other hand, maybe for the discussion later, what I also think, yes, for some indications, it's true that we should, regard them as one indication, but I'm a neuroscientist by training myself. I also think that there are a lot of commonalities between diseases which could be addressed also through DTX. So if you have, let's say, a solution, and I'm mainly working in neuroscience, for neurodegenerative disorders such as Alzheimer's or Parkinson's, there are also some aspects of it that could be used in one or the other disease, right? So it's not that we should also move away. I think we should not abandon this thought, but I think we could move away a little bit into, looking strictly at a disease or phenotype of a disease just with, in one, so to say, structure, but also maybe enlarging that a little bit. And that is where, data comes in, and where we've seen also by analyzing this data that this has value. And so I would like to stop here. Thanks a lot. I'm looking forward for the discussion.
Thank you, Nikos. Thank you for the quick introduction to ROX, but also how the company builder and the accelerator is being used here to form those partnerships, which we have heard here from some of the other panelists that are so important at this stage where the market is. Thanks for sharing those initial thoughts. Hope we have some time here to come back to those here in the discussion. Let me quickly hand over to Thomas Gornig. He's the commercial director from Teladoc. And we, in our discussion earlier on, we discussed that maybe putting an emphasis on Livongo and the DTX diabetes would be of most interest for the audience and in the context of the session. But now, without any further ado, I'll leave it to you, Thomas.
Thank you, Ralph. And yeah, exciting to hear the different perspectives. I'm really looking forward to the interactive part of the discussion. So we'll try to keep it brief on the opening statement side. So I've had the opportunity to gather kind of different insights. So previously I've been working with Nuna Healthcare, bringing a digital oncology platform to the market, where we partnered both with academic centers, but also pharma, and basically, driving both sort of the adherence goal, but also the real-world evidence goal in the pharma partnerships. And now working for Teladoc Health in the role of the country manager for Germany. And of course, here we are working very intensely on the Livongo programs to bring those into international markets. And of course, here we also have different commercial models ranging all the way from payer relationships, in direct contracts, but also thinking about DTX, market access like DIGA, employer relationships, as well as pharma. So really different angles. I think for today, I wanted to share a little bit my experience and the view on different DTX and pharma partnership models and what are kind of the advantages and challenges of some of those. I think there's broadly, from what I've seen in the market, kind of three different goals that are followed in these partnerships. Sometimes it's a mix, but it's kind of three categories. So one is really focused on adherence and being a patient support to the drug, and in the end, on the pharma side, being able to drive patient engagement and indirectly revenue. The second category I would call outcomes and reimbursement. So really having the joint goal to create hard endpoints on outcome benefits, either by the digital solution or in combination. And then the third bucket I would describe as the real-world evidence data bucket, which is really all about now having a digital solution that enables you to, in real time, gather data from the patient on patient outcome measures and so forth. So I think those three goals really relate to different models. So there's four different ones that I think have been successfully implemented with different challenges. So one is really a patient support model where the partnership with pharma is really geared towards driving adherence, days on therapy, and revenue by differentiating the product. Here, oftentimes, it's a development in a white label way, or a way that it's co-developed, as we've also heard before, with pharma to really have the best value for the patient and the support throughout the patient journey. Oftentimes, this happens, of course, in disease areas where the route of administration is a bit tricky, where there's a lot of content that can be explained to the patient to support. And I think one of the advantages of that model is that it has a very clear value proposition to pharma. It's something that is proven to work. I think the challenges arise in topics like scaling. So oftentimes this starts as a local partnership. Sometimes it's driven by local market specificities. And it's a challenge to scale then from one franchise of one country across to others. Now, the other model I would call commercial revenue stream to both partners, DTX and pharma. And you can focus really on using the tool to commercialize. And of course, for the DTX company, oftentimes the benefit lies in the commercialization expertise of the pharma player. Because oftentimes, especially if it's startups, there's of course a lack of scale and a lack of boots on the ground to really get close to the prescribers and close to where patients interact with HCPs. Of course, here's challenges. Here we got challenges like to what degree does the DTX stand in competition to the drug? Also, what's the incentive on the DTX side if there is already a reimbursement? But generally, a model that works. Now an evolution, and I think this is also something for partners that are a little bit more advanced also organizationally. An evolution of that is, of course, co-developing a DTX to be jointly reimbursed. So to have a drug with a DTX in the label. And then, of course, incentives are very strongly aligned because the goal is to really showcase the evidence for better outcomes and having those reimbursed by the payer. From the regulators' point of view, and also in terms of some of the organizations and organizational readiness. The last model is the real-world evidence data model, of course. I personally think this is one which will get much more important as we go forward. So here we can think of course, comparative effectiveness studies, so to really gather real-world data of different drugs and how they behave versus each other. I think also as we see endpoints becoming more important, like quality of life, in addition to the hard outcome endpoints, this becomes more and more attractive. And then, of course, I think we touched upon this before, the value-based reimbursement concepts. So now that you're able, post-market authorization, to gather data on outcomes in real time, value-based contracts become much more close to reality than they have been before. We see also that regulators are pushing in that direction. So we've seen the guidance of the FDA towards including more real-world evidence, towards especially in the cases, for example, in oncology, where you've got fast-track approvals increasing in number, and then having a focus on generating more evidence after the market authorization, including PROs. But of course, here the challenges often lie in the organizational readiness, also in the alignment of the commercial and the R&D organizations. We've seen challenges here, and but I think nevertheless this partnership model is one which will gain in importance going forward. So really looking forward to the discussion and hearing some of the experiences of different partnership models and what we see going forward.
Yeah, thank you for this introduction and first thoughts, especially on how to commercialize DTX solutions together in a partnership. We are always referring here to the later on discussion, but I can already foresee that we don't have enough time here to discuss all those interesting topics and subjects. So maybe next year, giant team, we need a bit more time for this round. Okay, let me quickly hand over to Stefano. Stefano is the global head of digital solution in ophthalmology within Novartis. And in our pre-talk, he mentioned that they are very active in certain areas, also including lazy eye treatments and so on, where they already have digital tools to support the patients on top of all the medication and other treatments Novartis is providing. But maybe you can elaborate a bit more on this.
Sure, thank you, Ralph. And what I thought I could do is actually to show a few examples of what we mean by digital therapy and to illustrate the type of partnership that we have. I guess you see my screen by now, Ralph, does it work? Yeah, I guess, yes. So okay. Perfect. So first, I think there's been a lot of confusion on what does digital therapeutics mean, and I think that's important that we're true to the definition, which is really high quality, clinically validated software to treat, prevent, or manage a disease, because a lot of actually what we call digital therapeutics are not. And they've been in different areas, so for mental health, diet and nutrition, and so on, delivered through different type of device now. What what I wanted to show is 3 examples of what we have done in ophthalmology at Novartis, and to illustrate the type of partnerships that we have for this type of digital therapies. So first, the whole goal is really to optimize vision through transformative technologies. So use the digital therapies as a way to improve the outcome of our product. And that's really how we focus. We look at the patient journey, as I think Johannes and many of you have talked about, and see how we can improve awareness, diagnostic, treatment, adherence to therapy, basically having twice as many patients, twice as fast for twice as long. So we look at the pain point for a specific disease and see if there is a digital solution that can really make a meaningful difference in the management and ultimately outcome of the patients. Now, one other element, and you see here the type of solution we have developed. I will go through 3 of them. The last one that I wanted to mention, and I think we didn't talk much about that so far, is really the real-world evidence. I think that's a very important element because more and more payers will want to see what is the actual outcomes of the treatments in real-life setting. And we have to digitalize the endpoint. That's a big focus for us, especially in ophthalmology, to ensure that patients can capture their measurements, not only in the clinic, but very much in the comfort of their home. And that comes with making these endpoints portable. So let me take 3 quick examples. First, on the awareness, how to improve awareness. We have a Xydra in US, which is a therapy for dry eye disease, prescription therapy. Now, most of the patients are not treated with prescription treatment. They keep using artificial tears, which are suboptimal. And a big challenge of us has been to ensure that these patients do get the RX treatments. And here the big barrier was actually getting to an ophthalmologist and get the diagnosis and the prescription. So we partner with GeniMD to make it very accessible. So you can just go on the platform on the Xydra, you're driven there, and from the platform you can access directly to a doctor. What we see, which is interesting, that 60% of the patients who start this online consultation end up with a prescription for dry eye medicine, Xydra or another one, because we cannot direct to only Xydra, of course, but it does work. So they actually accelerate this time to diagnostic and time to prescription in meaningful way. And here, that's typically the type of partnership that as pharma, we will not develop our own telemedicine offering, but use in partnership and integrate within our promotional activities this direct link to, in this case, GeniMD, but it can be others. So that's one type of partnership. Now, another one that we talked is when actually the drug becomes the digital therapy. In the case of amblyopia, it's a bad connection between the brain and the eye. So it's not a physical defect. It used to be, but was corrected. But just the brain is used not to suppress the image coming from the bad seeing eye. And you treat that by occluding the good seeing eye, forcing the bad seeing eyes to work. Now it's very cumbersome. And what we have done, we acquired a therapy to actually replace the patching with a dioptic therapy. So a gradual change in the occlusion of both eyes. So of course, I don't know any kids who would not prefer just playing a video game 1 hour 1 hour per day instead of having to wear the patch 6-7 hours per day. So it will be a huge change, and I think this kind of a case where we have digital therapy treating and curing disease will make a huge difference in the management of the patients. Here again, we're not a game company. So we partner with Ubisoft to design the game, this specially designed game for the treatment of amblyopia, and with McGill University, who own this the science around the dioptic. So finding this collaboration with where we have gaps to ensure that we manage the distribution of the product, the commercialization, but the design of the product to make it really engaging is done by experts. In this case, Ubisoft was key to success. And then finally, a last one on the patient adherence to treatment. For wet AMD, we have a big challenge with about 40% of the patients not going to the clinic and dropping off therapy. So we partner with TDAC Healthcare, who has developed medical grade visual acuity assessments, which can act as a remote monitoring device. Using their own device, the patients can actually check their visions on a regular basis. And if the vision is declining, the device automatically alerts the patients that the vision is declining, as well as the treating physicians. So it's a connection between treating physicians, patients, and their device. Of course, that means that here again, we have to validate that, and that's what they did. TDAC has confirmed that it's equivalent to the in-office VA assessment, and that was key to get credibility. And that's actually, it's been now launched in France, US, Germany, and Belgium is, Spain and Belgium are next. You can see the impact in terms of success for this device, with more than 3,000 patients, a lot of 120,000 tests done, and so on and so forth. But here again, I think we partner with them. They manage the owners of the device. They own also all the patient data. We co-promote that to our treating physicians for the benefit of our patients. So here again, I think we have a mutual interest. And with this partnership, we could generate the data so that they can now go to healthcare system and get reimbursement for this type of solutions. So it's also a win-win to allow the startup to get the evidence in order to get ultimately a reimbursement. So I think I showed you 3 examples which are very different in the way we partner at Novartis, but have been very successful. I think the key element is really on how you ensure that you are aligned strategically from the start. You're very much aligned and understand and find the partner which complements the pharma companies and make it really a win-win. So we can ultimately deploy these solutions at scale and get the benefit for our patients. Back to you, Ralph.
Thank you, Stefano, for giving those concrete examples of how Novartis is providing digital services in those therapeutic areas, also sometimes replacing the existing treatment or improving the existing treatments. So guys, also out there, I must excuse because we don't really have a lot of time left to discuss all this, but I think the intro statements of all the panelists, they have been so interesting and provided quite a very clear picture on how pharma companies are currently deploying DTX solutions, and on the other hand, how DTX companies are envisioning the potential collaboration. So I think you must be very enlightened all in the panel, because you're just friends. It looks like that in the next few years, maybe I'm wrong, I mean, here we are the partners of the next few years. So pharma is working with software companies, software is partnering with multiple pharma companies, developing jointly on those DTX solutions, and it's mainly to support existing drug treatments. So I think it's a great future, don't you think so, Johannes? I mean, is that the future for the next few years? It's all about partnering, competition.
Yeah, I think so. I think this is really exciting and shows that I think it's interesting that everybody is thinking along the same lines. And I think one very interesting point that was raised, I think, by Susanne and also others is actually, I think what the startup world can help us with is sort of getting us to think about new business models and new ways of making money also with these solutions, not just seeing them as an add-on to our more traditional sales revenue sources, right? So I think super exciting, and yeah, this is only going to work if we all collaborate together to make the best outcomes a reality.
Yeah, perfect. Klaus, what do you think about that? Are they all your friends?
Definitely, yes. And as I'm responsible for partnering with external companies in the field of digital health, yes, you have to pick the right partner, and that's a very important thing, because it's not only about technology and how to embed it in the system. It's also about content and how to develop the right content for the patient and for the doctors, so that the solutions get used. So only if solutions are used, they can have an effect. So important to have the right partner covering not only technology, but also supporting in the right content for the solutions.
Yeah. And Susanne and Thomas, Stefane, you raised your hand.
Yeah, we don't have a virtual raise the hand, so I did it for it. No, I think you're perfectly right, Klaus. I think that the only big challenge will be how do we scale that up? Go from a few percentage of the patient using these solutions to a really majority. And we also saw at time of the COVID, there was a escalation of telemedicine actually solutions, but now that it's getting better, it seems that it's getting again worse, but it also went back a bit to the previous COVID era. So it's how do we make sure that we really scale up these solutions and change the behaviors also for physicians, and that comes also with incentive. How do we incentivize them to use this type of solution more, to recommend them more, to integrate that as part of their practice management, and not only on a case by case.
I have two thoughts about that. I think, first of all, it's important that there's a clear value proposition for the physicians, because they are the ones either prescribing or recommending digital solutions. So they really need to believe in it and feel confident that it adds value to the patient. And I think, second, pharma and DTX, we have to co-own the user acquisition. It's not only the role of the one or the other, so we need to use all the channels we have to really drive the user acquisition, so that you get relevant number of patients on the platforms, and providing also the relevant data and value proof to all the stakeholders.
Right. And Thomas, would you have to bring in mainly your competencies in creating those value-based contracts, risk-based contracts to those partnerships? Do you see that as one of the major roles from a DTX perspective?
Yeah, definitely. I think, as we talk about DTX and pharma partnerships, I think the role of the payer and how this integrates in kind of a relationship between the three will become increasingly important, because the reimbursement as such will become more important, but also the role of the data for the pharmaceutical itself, especially post authorization, I think will change. And we've all been talking about value-based contracts for a long time, right? But the time we are at now, I think, is the time when it can start to really take off, because we are now at least slowly getting adoption by the technology that can enable the data that is the basis for those contracts. So I think this is just something where we are still in early phases to figure out how it will exactly look like. So I think it's very exciting what's ahead.
Okay. And Nikos, from your perspective, will we see those platforms platform, DTX solutions, created by pharma, or within those partnerships where we serve multiple conditions, because you mentioned that lots of the digital services provided for one disease area could be also used for another disease area.
Yeah, I mean, that we will see such solutions, I do believe. Whether it will be pharma who builds them, I'm not so sure yet. I mean, also, you know, what Thomas was just saying with respect to data and value-based healthcare. I mean, ultimately, if you look at such settings, you know, there are really the interests are not always aligned. You know, for instance, between, you know, the, let's say, pharma company and the payer. So you need to have, and this is, you know, what startups are also doing, maybe a mediator, right? So I think we should be quite aware what our role will be as pharma. At the moment, I think we're still exploring this. Yes, you know, we are also still looking at we could build such a thing. But I think, I don't know who mentioned it in the beginning, on the one hand, we provide a lot of trust in, you know, that the things that come to the market, you know, fulfill the, you know, the required, you know, regulatory as well as, you know, clinical validation. There we have a lot of trust. But on the other hand, from, you know, and we are taking a very patient-centric view, there's a mixed, so to say, trust, you know, towards pharma in terms of, you know, I will provide my data, I will share my data. It's too early to tell, you know, where this will go, but I think we will definitely see these platforms. How and who will build them, I'm not set yet, so it's too early to tell. Yeah.
Okay, thanks a lot. Sorry also for rushing through that discussion part here of the presentation of this session. Thanks a lot to all the panelists. I think that this was really a very insightful discussion and presentations from all of you guys. Thanks a lot. I hope that you outside, you also valued this 75-minute, and I promise next year we will fight for more time to really dig a bit deeper into this very, very exciting topic. I think there will be a recording for that session made available to the participants of iPads. And with that, thanks again to all the panelists, and I will now head over to the Giant team. Thanks a lot.
Thank you.
Bye-bye. Thanks a lot.
Thank you. Bye-bye.
But we also see a lot of problems already within those trials. Most of the trials today, they start the trials, but having not met their recruitment goals. So the vast majority, they envision to have maybe 500 patients in the treatment group or in the control group. But they, at the start of the trial, they have not been able yet to recruit all of them. So that's a normal thing. And then also a normal thing within those clinical trials today is that quite a big share of those recruited patients, they don't stay. They don't stay until the end of the clinical trial, and recruiting replacement, that's quite an expensive thing to do. And last but not least, another thing which also made us look into this segment of the digital health market is the fact that more and more investors are looking into it. And maybe they see that digital therapeutic tools are a good way of monetizing within clinical trials, and lots of money has been poured into this, the vendor landscape, with big shots of a few hundred millions of investments into that market. So that all raised our interest, and hopefully that's also the fact for you guys sitting there at the computer at the moment. But I would now like to hand over to Isabel to give us a quick intro in what you have found when you did this research project on the platform.
Yes, thank you. Thank you very much, Rolf, and thanks everyone for being here. let me go ahead and share a few brief slides to introduce this topic. Great. So as Ralph mentioned, today we will be discussing the landscape and the changing landscape of decentralized clinical trial solutions. And when we speak about decentralized clinical trials, it's a bit of an umbrella term to address new ways of doing clinical trials that are now conducted in part virtually or sometimes completely virtually, which allows the patients and the providers to do this from the comfort of their own home instead of from a traditional trial site. So this is something to keep in mind as we move through the panel discussion today. So let's take a look at the traditional ways in which clinical trials had been. So I think that many of us are aware of the fact that there were many issues in running clinical trials, and it was causing lots of problems in terms of, first of all, the budget of the clinical trials, trials running over time, patients dropping out. So one number that we see that's sort of commonly thrown around in the industry is that 80% of clinical trials in the US are actually delayed by at least a month or even stopped because there's problems reaching initial recruitment goals. So they just can't get enough patients to join the clinical trial. And this is because in the US, about 70% of patients live more than 2 hours away from trial sites. So we know that oftentimes the same trial sites are being used over and over again. It's the same large universities and research hospitals, and it doesn't allow patients that live far away or live maybe in rural areas to participate. So given this and other burdens to participation, actually 30% of patients drop out of clinical trials. And when they do this, it causes massive problems on the budget side, so that on average, it costs almost $20,000 to replace a patient during a clinical trial. Even though this varies, of course, from trial to trial, it's about 3 times more than the cost of actually recruiting a patient. So trials are very much incentivized to keep patients as long as possible, and at the same time have a lot of difficulty with this. So given these problems, it's not surprising that we're seeing an increase in the number of clinical trials that are conducted virtually. So this simple graph just shows the number of clinical trials that have some element of decentralization on the y-axis against time. And as we can see in 2020, there was about 1,000 clinical trials in North America and Europe that were conducted with some kind of element of decentralization, at least in part virtually. And given that there's 13,000 trials going on, that's almost 10%. But what we can see and what we project in 2026 is that we will have up to 6,000 trials that are conducted in part virtually, and that's going to be almost 1 in 3 clinical trials. So we expect that this is going to be a huge paradigm shift in clinical research. So what are some of the actual ways in which these virtual trials are done? So what we're seeing here is just a simplified view of the different clinical trial activities, from study design all the way over to data analysis and reporting. And I just wanted to bold a few of the alternatives that decentralized and digital tools are allowing to take place virtually. In the interest of time, I won't talk about all of them, but some of the interesting ones, for example, are in site selection and patient recruitment. We see that digital tools can massively improve the way that patients are being recruited. So if the traditional way of recruiting a patient was maybe even a physical flyer or speaking directly with their general practitioner, now we can have massive social media campaigns on Facebook or Google Ads or Instagram or something like this that can actually reach the right patient groups. We also see that real-world data is used to actually identify where the patients are located and use this to actually optimize where the physical sites are. In terms of patient onboarding, this is another large opportunity for digital tools, because we see that this can be done with some kind of like online education, or telehealth can be used to actually present the education and the e-consent for the patient to be consenting into the clinical trial. The same is the case with data collection, where we can use virtual tools such as mobile apps to keep track of the patient-reported outcomes, or wearables can also keep track of outcomes as well. And this is a much more efficient way than the traditional sort of pen and paper recording, in which the patients would maybe have to write down what their symptoms were and then go into the trial and actually report it maybe often weeks later. Maybe they had forgotten what their symptoms were when they took the medication. And this kind of ensures a higher level of data quality, while at the same time, for data monitoring, it's a much more efficient way for sites and for the trial sponsors and for the patients themselves to all have access to the same platform in real time. So there's definitely a lot of benefits that are being shown in terms of efficiency and data quality. So who are these players that are actually allowing this decentralized market to move forward? So at Research to Guidance, as Ralph mentioned, we have run a pretty extensive market study, and we found that there's 6 different groups of providers, or 6 different archetypes that we have called them, that are providing services across the clinical trial value chain for clinical trial sponsors. So the first of these is the real world data providers, or what we've called the data repositories, and they specialize in providing real world data sources for trial sponsors to have a better understanding of how their drugs are performing in the real world, and have a better understanding of who the patients are that are most affected by these conditions. And these are the most helpful, primarily in site selection and recruitment. Then we have our patient engagement specialists, and oftentimes these are some kind of software or tech solution that allows for the patient engagement long-term throughout. And this can be done via the use of coaching or via a mobile app, some kind of software solution, or telehealth. Then we have the data capture services, which are longtime players in the market, and they're essentially the solutions that allows for the data to be taken from the patient and then stored in some kind of database and displayed to all of the active stakeholders in the clinical trial. Then we have supply chain managers, which are the logistics coordinators, and these are a rather smaller subsegment of the market that are focused entirely of having to send, of course, all of the medication instead of to a trial site to the actual homes of the patients that are participating. And then finally, we have the end-to-end solution providers, and these are the DCT companies that are providing services across the value chain, all the way through from study design to data analysis and drug and device supply, and oftentimes filling in gaps in their service offering via partnering with smaller, more niche providers shown on the chart. And then last but not the least, we have what we've called the digitizing incumbents, which are the CROs that have long time been in the market providing services for clinical trials, for traditional clinical trials, which now, in the case of COVID and in the case of the rapidly digitizing world, are now a bit scrambling to add decentralized services to their portfolio. And they're doing this mostly either the acquisition of smaller companies or directly partnering with, for example, end-to-end solution providers. So we can see it's a very segmented market, but it's also very dynamic as well, as many of the players are interacting with each other, partnering, acquiring, and it's more of a co-opetition market at this point. Something that we have not spoken about, but it's our focus for today, so I wanted to briefly mention it, is the role of digital therapeutics in this overall market. So we see at Research to Guidance that there's 2 potential roles that digital therapeutics can play in the DCT market. The first and the most important is digital therapeutics as trial sponsors. So as we see that digital therapeutics is a rapidly growing market, they will have to start running clinical trials so that they can show that their solution works, so that they can reach some kind of reimbursement or regulatory status, and to differentiate themselves from competitors. So we're already seeing some interesting examples of this happening in the market. Like, for example, shown here, we have Click Therapeutics, which is a pretty well-known digital therapeutic that they have recently partnered with the end-to-end provider from Google, Verily, to run an entirely decentralized clinical trial on their digital therapeutic for depression. And this has received some media attention. We expect that there will be more large trials like this in the future. Then something that is a bit more of a future view, but is also quite likely, is that digital therapeutic companies will actually become providers and start to offer a service offering in this market. And what I mean by this is that digital therapeutics hold a wealth of patient data and patient outcome data, specifically because many times the patients are tracking their day-to-day outcomes, maybe their pain levels or what they've eaten or their activity. And this is all real-world data that can later on be used to support clinical trials in terms of the patient recruitment that I had mentioned, or post-market safety studies. And many times digital therapeutics companies, they really know best how to digitally keep a patient engaged, and they have great platforms with high user retention rates. And so these kinds of platforms can actually engaged during a clinical trial. And this is what we're seeing today in a few examples, but the most prominent one probably being Belong Life, which is a digital therapeutic solution for cancer, among other things. And IQVIA, one of the largest CROs on the market, has recently purchased their solution for the long-term patient engagement in clinical trials. So we could expect that this is a trend that will become more popular in the future. And as this market continues to grow, we expect that it will reach over $9 billion by 2026. So we understand that this market is growing, and there's certainly a lot of opportunities for market players. Great. So just to leave us, I guess, on a positive note, what are some of these claims that these decentralized clinical trial solution providers are claiming, and why have they been so successful? So one of the main ones, as I have mentioned, is faster patient recruitment. So using data mining and EHR tools, we can better identify patients for clinical trials, especially true in the case of rare diseases where there might not be so many patients available to join a clinical trial. We see that there's higher data quality because now we have instant data upload and more data that's actually being captured from the sensors and from the patient-reported outcomes. And potentially it's a higher quality and less transcription errors than a patient recording it with a pencil and a piece of paper. We see better patient retention because patients can be engaged with gamification tools or reminders, digital coaching, and because they're potentially less likely to drop out if they don't have to, go into the site every day. We see improved rates of patient adherence to medication. So as we understand, at least in the case of potentially a pharma clinical trial, the data is severely discredited if the patients aren't correctly taking their medication. So we see some companies and some solutions that are actually able to track the adherence to the medication with potentially taking pictures of the patients when they take the medication. And there's less room for false patient-reported data. We see, very importantly, an increase in patient diversity because once you remove barriers such as lacking transportation to a trial site, more patients can participate despite their location, despite a disability that they may have, despite a chronic condition that they may have, or other socioeconomic factors. And then finally, all of these together come up with a reduction in the time and cost. So the clinical trials can be conducted faster with less delays and ultimately reducing the overhead budget. So thank you very much, everyone. I'm very much looking forward to this discussion. And then I will hand it over now to my next speaker. Excuse me.
Yeah, thank you, Isabel. Thanks for this great introduction. Maybe quickly hand over to Marcus. Marcus from USense Lab. Providing my green digital solution. I think last year or this year you got listed on the DIGA, on the German digital health app directory, allowing you to get a prescription by statutory health insurance companies. And the special thing about your company and potentially also about your organization is that you have conducted a clinical trial all by yourself, and it was all virtual. But I leave it now to you to explain what you have done.
Great, thank you, Ralph. I hope you can hear me and can see the first slide well.
Yeah, that's fine.
Great. Really, thanks for having me. I'm really happy to talk about both sides, the digital therapeutics side and how it is linked to virtual clinical trials or decentralized clinical trials, and why, as you said, Ralph, we have done it all by ourselves because we really believe that these two things belong together. So in my first impulse here for the first slides, I really want to show you how we want to also use decentralized trials in the future and why we're doing it by ourselves. And then I'm also, of course, happy to tell you a bit more insights how we have done it in the very first time. Briefly to my background, I'm a co-founder and the CEO of USense Lab, and I'm coming from basic research. I'm a trained research scientist, and as such, as a former research scientist, I'm still today very much motivated and inspired by translational medicine, so taking cutting-edge research and turning it into products. But of course, we are not in the space to have just products, but the actual ultimate goal is we have a sense that believe in precision medicine, and whether you call it the right treatment to the right patient at the right time or a bit shorter, the best treatment as the first line treatment. The fact is that currently we are not yet there. The reality is that people feel more like in a labyrinth. And even if you are treated by medical guidelines, the first treatment usually is taken from a set of standard treatments, and then stepwise you get to the treatment which is actually effective for you. In a world where at some point we would have a predictive biomarker, kind of a digital companion diagnostics, where for each, let's say, classical drug, we would know whether a treatment is effective, or maybe even more important, whether it is not effective. So you could actually skip this maybe first line treatment and get directly to another one. Or maybe you have a software which tells you what is the dosage of the treatment, or what is the perfect timing of the treatment, whether you should take it in the morning or later during the day. So that would be kind of the susceptibility biomarker, or risk biomarker sometimes being called. Or a third one would be where the software is the active ingredient in itself, making it a digital drug, which usually is a precursor to it, is a response biomarker. So in this biomarker, digital biomarker realm, I think it's a way to digital or the future to precision medicine and digital therapeutics. And there is where I believe we have the highest impact of decentralized trials. And that's why we do it in New Sense Lab by ourselves. So we have learned to use algorithms for changing patient behavior. This was already mentioned, that it is about adherence and engagement. And we started with a prescription digital therapeutics for treating migraine based on behavioral interventions. And we continuously use real-world data to improve these algorithms. We have also algorithms that inform or maybe even drive clinical decision-making. And again, we use the data which we collect, the real-world data, to improve these algorithms. But at some point, if you really have the claim of a digital biomarker, just real-world data or real-world evidence is not enough. You really need to prove and show that the claim you are doing is really predicting the response of a certain drug, predicting the right time, or is an active ingredient in itself, kind of reprograms the brain. And for this evidence level, you need to go back from the real-world evidence to RCT, the gold standard, and this has to be done in an integral part, and has to be done while the product is already on the market, and also not so kind of post-authorization and increasing the level of evidence needed. We have done this actually, so we have a DIGA, a digital healthcare application in the German market, which is also the only DIGA at the moment. I think we have 24 DIGAs, which is approved as a diagnostic tool, so it can distinguish the phenotype between tension-type headaches and migraines. And this is used within the DIGA to inform clinical decision-making. And we will continuously improve the product and validate, or doing a clinical validation or performance validation of these algorithms to put them one level up from an algorithm to a digital biomarker. So most of what we are doing in New Sense Lab is really for a certain type of diseases. So if we are in other areas like oncology, you may argue differently where decentralized trials become a value, but we argue for chronic diseases with episodic manifestations, where it is really about long-term monitoring in combination with digital biomarkers. So I think it is really both this therapeutic focus area and digital biomarkers with decentralized trials. We have proven this for migraine. MSense Migraine is the first prescription digital therapeutics we have brought to the market. At this moment, we have about 5,000 patients under treatment, and the actual access study has been done in a virtual trial. But as I said, we continue to do this. And by this prologue, let me really briefly, and then we can dive into the details, answer these questions. Ralph, you have asked before, what's the difference? The difference, I think it's very clear. We want to have a decentralized version because we need a richer diversity of patients for this heterogeneous patterns we see in the episodic manifestations, whereas actually the digital solution assisting running virtual trials. I would say it goes really both ways. It's not only that the DTX is assisting, and so that we can actually also run clinical trials for other companies, for example, as was suggested by Isabel, but it's actually also going back. The virtual trial is helping the digital therapeutic solution. So I like to quote Stefka Lusk, our head of clinical operations. She talks always about a perfect marriage. So the two things really belong together and should not be thought of separately. And the highest value, as I've argued, is in this reverse translation. So this continuous validating algorithms and getting them into digital biomarkers. And the biggest challenge I see for the future is that we really need to think about product lifecycle-based evidence generation or evidence oversight. And I'm deliberately using the wording here from the FDA. When the FDA talks about learning algorithms, they think about artificial intelligence and machine learning-based software as a medical device regulatory oversight. So there it is more the authorization get to the market, and you have to onboard the regulatory requirement into the product. But now if you think about reimbursement, value-based pricing, you need to, in the same manner, onboard the evidence generation. And the evidence generation then is best done in a decentralized version. So by this, I hope to give some impact how we think at New Sensitive about this field. I'm happy to answer questions in the end of the panel.
Thank you, Markus. Very impressive. So you also raised the importance of those two sides coming together, DTX companies and vendors of digital solutions to support clinical trials, to, how you phrase it, to onboard this creation of clinical evidence into the normal process of developing DTX solutions, which I think it's a rather complicated thing to do. But on the other hand, is there another option as of using those digital tools to do that? So let's quickly jump over to Adam. He is one representative of a company which has concentrated on providing these tools and services to conduct clinical trials hybrid or virtually. Please meet Adam from CureBase. It's a US-based company that also ventures into the European market now. And Adam, maybe you can elaborate a bit more on how you see those tools are supporting clinical trials in the future.
Absolutely. Thanks so much, Ralph. And thanks everybody for the opportunity to join the session today. As Ralph mentioned, I'm with CureBase. We are a service provider. Just a little background on myself. I will say I'm an operations guy, not a BD guy. So I will really focus in on what the practical kind of applications we've had with our clients around running virtual and decentralized trials, hybrid trials, in particular with a focus on DTX, since that's our topic here today, and also a big kind of area for us that we have a lot of interest in. So prior to joining CureBase about 1.5 years ago, I had spent over 10 years in the clinical research side. I actually started as a clinician and worked at larger CROs, worked in academia for a few years, and was at a large pharmaceutical company when the pandemic hit. And like many of us, I was scrambling to keep my my study that was running in 8 countries and with hundreds of sites up and going, and saw things that were happening in this space to try and basically take the technology that was already there and being used very well in other industries and how we could start continuing to really apply that to our clinical trials here. So yeah, at Curebase, we have basically 3 different ways that we are able to optimize for these type of trials. One, of course, is the software. Software is essential when you're running a decentralized or virtual trial, of course. So, we have the ways to capture data, the eSource, the EDC, from the clinicians. We have ways to capture data from participants through eConsent and ePro and things of this nature. But I always like to say, and my software guys are never here, so I don't have to feel bad. Like, software alone isn't enough, right? You need kind of what we've found is you really need to have someone on that same side that understands the software to be able to deploy it successfully. So we do offer professional services, those that almost align well with like a CRO, right? So project management, data management, site management, monitoring. And we operate what we call a virtual site, meaning that we have coordinators and doctors who actually interact directly with participants. So just a little context around what our role is in these type of studies. I do think that it's really important to keep in mind, and we have a lot of terms, and Isabel already kind of walked through to kind of level set on some of those. So thinking about fully virtual trials, only a very small percentage, what we're seeing here at Curebase and what I'm seeing outside of Curebase even, are ready for this fully virtual model where we are, doing everything remotely. I mean, we're talking maybe 5 to 10% of trials at the most. So much of what we do and much of what we see being done is around the hybrid space. So keeping in mind that, as exciting as it is that we're using these additional technologies, remembering that using and leveraging the existing infrastructure that's there, whether it's just the people or it's also the people in the physical sites, we still need the researchers that have been doing this a long time, right? The doctors and the coordinators. So we try as much as we can to use the hybrid model, making it so that we can give participants the option, if they want to have their blood collected at home one time, or if they want to come into the clinic, if there are certain things that need to be done from a diagnostic perspective and they need to go into the clinic for certain visits. So I think that one thing that we've learned is to really keep a flexible approach in mind when you're designing these type of clinical trials, whether it's for DTX or other indications or other therapies. That way, you kind of get the best of both worlds. You get patients who are engaged because they have the ability to use their own devices, and we are meeting them where they are. But they also have the opportunity to interact with highly skilled research folks and institutions that have been doing this for a long time. In terms of the type of studies that we do and where my context comes from on this, so in addition to doing, the typical type of, drug studies and device studies, we've really dove, headfirst into DTX, much like everyone has been saying here. We see this perfect marriage between DTX and these decentralized clinical trials for the obvious reasons, a couple of which I'll dive deep into. We've done, we've either completed or are in progress with at least a dozen studies in the DTX space. And I think that, so kind of diving into what it is about that we've seen that really makes for that great marriage, and how I've seen some of these pain points that I was experiencing in pharma and at CROs kind of melting away as we perfect this model is, you have a digitally delivered treatment, right? So why not have, the ability to do this within a patient's home? I mean, it seems kind of silly to have a participant drive all the way into a clinic just to have a treatment delivered that they're going to kind of self-administer, and they're going to do that in a clinic setting and go home. Honestly, we're actually seeing in our discussions with regulators, and payers even, they like the idea that this is being done in the real world kind of environment. Like, this is where ultimately these treatments are going to be administered to patients in their homes or wherever they choose for them to be. So it really only makes sense that we design our trials in such a way that really mimics what you're going to see in the real world. Integrating the clinical data with the DTX trial data, I think is really something that is powerful and something we haven't mentioned here yet. So analytics is an area that has been exploding in clinical trials for a long time. Our ability to be able to, in real time, understand what's happening with the participants, what's happening with our clinical trial data is crucial. And being able to pull in and integrate the DTX solution with the clinical trial data platform and give our clients as well as our operations teams the ability to look at those data in a meaningful way has really allowed us to optimize recruitment, retention, even things more serious things like safety, when you can be able to see those things in aggregate and make connections. Certainly, we see faster trial participant recruitment, especially when you start talking about things in the rare disease space, where you might have participants that are spread over vast regions. Again, there might be 1 or 2 visits that they need to do in a clinic, but a lot of it we can be doing from home and not necessarily having these patients travel oftentimes very long distances or trying to enroll 20 sites for 20 patients, basically, which sometimes you see in these type of rare disease trials. Certainly that increased convenience for participants is something that we hear from them as well. We really do like to gather feedback from participants. This is something that's very refreshing to me, being someone who has come from kind of the traditional clinical trial paradigm and world, is to learn, I'm learning from the software side of things and things like usability research and understanding the participant journey. And I think that we're, as a community, blending the best of both worlds in terms of what's happening with software and what's happening with the clinical operations world.
Adam, maybe I would have a question. And
please.
Sorry for jumping in.
No, please.
But also, we have because we have also started a bit later. Yeah, we maybe I would like to ask a question to all the 3, which have already shared their initial thoughts. And I like this term of a perfect marriage between DTX companies and companies like Curebase to supporting each other. But my question is to all of you, whether you see that out of this perfect marriage, there will be a divorce coming up rather sooner than later, because then both parties will see that they are targeting the same company, the same trial sponsor, because DTX companies, they realize that, they have something which is really of great interest for those clinical trial sponsors. And you from Curebase and the like, you find, wow, they are knocking at the same door. So my question to all of you is out of those perfect marriage, is there a divorce showing up rather sooner than later? What do you think, Markus?
I mean, I said it's a perfect marriage. I didn't say it's an easy marriage. I mean, we did it all in our company. In this sense, we cannot split apart because it's one company, but we deliberately didn't look for a service provider doing it, because it would be a marriage which could break at some point. But also, as you summarized in the end, it is, of course, very difficult. So it is for us not so easy to do it. And I also mentioned that in certain diseases, it's probably more easy. In others, you need a hybrid approach. And then you could really think about that it is good to have a service provider, because the actual advantage for us is really this onboarding concept. If you really need it for value-based pricing in a continuous collection of evidence as the same. That's why I use this analogy with the FDA. And if you have an algorithm which is onboard learning, you cannot just give it somewhere away. You need to onboard it directly. And this cannot even from a regulatory point of view break apart. with the reimbursement, it can of course break apart, or maybe at some point it is good to have different providers addressing different questions here. So, but for us, it is really important to have it at the moment united.
I would say, just going off of what Marcus said, that I think we're still many years away from seeing digital therapeutics companies have well-rounded service offerings for decentralized clinical trials, just because, I mean, immediately the only service that they could immediately provide would be some kind of patient engagement. And we're already seeing that the market is favoring more end-to-end solution providers. So if anything, potentially the more excellent digital therapeutics platforms, they could be licensing out just this one very small aspect of patient engagement. But I don't see that it would be a major threat to companies such as Curebase or end-to-end providers that already have a well-rounded service offering. And especially because digital therapeutics in general, I mean, it's an emerging market. Many of these companies are more in the scale up or growth phase and looking into other business models. And I haven't really seen, besides this one example that I mentioned with Belong Life, I haven't seen much movement of digital therapeutics already looking into clinical trial management.
And it's certainly something that we consider as well. I think that looking to, historically, right, what pharma did with CROs, even large pharma companies ultimately decided it's just not worth it. We're going to outsource things like monitoring, and because you have to be able to quickly scale staff as well, right? It's like you have this new, if you're a platform company and you're going to have multiple DTX, the ability to quickly operationalize and pull together skilled staff to do these type of studies it's quite a lift. But I think we will find companies that have the infrastructure to do that within the DTX company, and we'll see probably a mix.
Mm. And, maybe it's a good time to get you in, Franz Benstetter, professor at the University of Rosenheim, designing those clinical studies. So if you, in the future, if you design those clinical trials, how much would you have to look into the service offering of DTX companies, and how much would you have to look into the service offering of companies like Curebase to then design the clinical studies? So how much would you basically know all those companies and the service offering in order to design the best-in-class clinical study?
Thank you very much for the question, and sorry for being late. I had a problem. I think the issue I would like to talk about, or I wanted to talk about, and you summarize it, Ralph, in the question is it has to be a very clear cooperation when evaluating this kind of trials. You really have to understand from the beginning what does it need, what exactly is the intervention. And I think there's a huge opportunity in a cooperation, for example, including things like design thinking. I call it the new world of evaluation, accompanying in an agile way the companies to setting up the kind of, call it new solutions. And for this reason, it's not just an evaluation in the end, but you have to be part of the whole program from the beginning. And for this reason, it's perfect, because with this kind of new, rapid spread of the new forms of healthcare, we can get extended and accumulated data. From the point of view of a researcher, we can do shortened and more effective clinical trials. And therefore, I believe we have a win-win situation between business development and the evaluation. Because with the new data, with the better data, I believe we can use really the power of the data, and we can also use, let's say, a better statistics for an outcome. For this reason, coming back to the main question, I believe working together from the very beginning, evaluation and setting up, let's say, of the new program, including DTX, is the key for agile and for new ways of healthcare forms.
Okay, so it's not either or, it's basically bringing them all together and then forming a well-designed clinical study. Let me conclude and come to the last question to all of you. In 2 to 3 years from now, where do we are? Will it be a normal thing yet to conduct clinical trials in a hybrid mode, or will it be still an exception? What do you think? Maybe starting with you, Adam.
Sure. Yeah, I think that increasingly we will see the hybrid model being used. I see it as a spectrum, right? You know, you might have some that are very much still requiring a lot of in-clinic, whether that's in oncology or other therapeutic areas that require a lot of kind of in-clinic visits, but there's more and more that we can do from home. So I think that increasingly we will see hybrid being used, and that over time that will just be reinforced.
Marcus, how about you? How do you envision the next 2 to 3 years and the next clinical trials you conduct, all hybrid or virtual?
I mean, 2 to 3 years is probably really too short a time period. So we will see a more dramatic change, probably more in 5 to 10 years. Whether it's hybrid or not, it really depends. I mean, there are diseases where you need to draw a blood example, and then it doesn't really make sense at the moment, at least. Maybe we increase there as well. To have it fully digital. But in the migraine space, it makes a lot of sense. In many other disease areas, it makes a lot of sense. And I'm sure that we will see from Ucentive, but also other companies, the next trials where we have validated algorithms. And then it all depends whether we accept real-world evidence for reimbursement. Then maybe there's not such a pressing need. But if we want to have really RCT evidence, if we want to have causality, there will be more need for having really RCT trials, and then we will see more of these virtual clinical trials in the mode we are doing it at the moment. And I guess this will not change. I think we will actually not completely rely on real-world evidence alone. And in this sense, why I think really in 5 to 10 years, we see much, much more of this.
Yeah, Franz, do you also agree to this? Is it also your perspective?
I also believe we will go definitely more and more into virtual clinical trials. And as mentioned before, it also has a big advantage because we can also better see the patient environment, the stakeholders' interactions. So we have a lot of more opportunities in this kind of virtual clinical trials than in the status quo as we have it right now.
Thank you. Isabel?
Yeah, as everyone has already mentioned, I see it highly unlikely that we'll see many virtual trials entirely virtual trials beyond just the case of digital therapeutics, and the majority of the trials will be more taking a hybrid approach. And in terms of the market, since this is what I had spoken about before, I would see that, I mean, now we're in an interesting time because COVID provided a large opportunity for many niche players. But I think in the next few years, we're going to continue to see consolidation so that the CROs are likely going to acquire capabilities for decentralized clinical trials, either with partnership or acquisition of companies. And we will likely see that the largest players will remain the largest players in terms of the outsourced clinical trial research activities market.
Okay, well, I think for some at least in this panel, that's maybe a role's future. I would like to thank all of you for this very interesting discussion and also your initial thoughts about this very interesting topic. I know that the time was really limited, and I will definitely talk with the Giant Health team here to carve out a bit more time here to talk about this in more length next year. It is a topic which will stay, I'm pretty sure about that. And if we look at the digital health market overall, this is a segment where we actually see that real money is being made and will be made in the future. So with that, I hope the audience has gained some insights from our discussion. I think there is a recording, so when you have missed this session, you have a second chance to look at it. With that, thanks again for all the panelists, and I would now like to hand over to the Giant team to lead us to the next session. Thanks a lot again. It was a pleasure.
Thanks so much.
Thank you.
Thank you.
Applause for them. Thank you. Okay, so thanks to Ralph and his team. And I really want to thank the AV team today, because what they're doing today is having live face-to-face, they connect people around the world in real time across different countries. And it's been almost seamless. So well done to the team at the back for making it work. It's not easy doing hybrid events. I was in Dubai last year at the DTX conference, and they had about 100 staff running around trying to make hybrid events work. So thanks to you guys to making it really seamless for us. So as you know, we're talking about digital therapeutics, and our next conversation is on the brain, I guess. It's all going to be the really futuristic sci-fi look at perhaps how we interface with our brains going forward. The BCI, the brain-computer interface, is really exciting. You've seen the work by Elon Musk and the kind of Neuralink thing that's going on. And it gives wonderful opportunities to insights into our brain, to behavior, how we can alter that going forward. I remember when I give a lot of keynotes around the world, I talk about the concept of the upload. We know by the WHO's own standards that we're going to be 14 million health workers short by 2030. This is their own kind of work they did back in 2015. So when I think about how do we train the next generation of doctors or students or healthcare workers, how do we increase the number? Maybe the BCI in the future will be their solution. Could you imagine training a doctor in 10-minute upload of information into the brain, so they immediately come out with a medical degree, for example? Could that be a possibility of that singularity that we talk about by 2050, often coined by the team over in the US? So who knows where this may lead to? Are we ready with the slides for the next one? Okay, so we've got another minute or two minutes before we raise the slides. So as you know, the Giant event has been running for 7 years now. When we first started in 2015, I'm the co-founder with Barry Schreier. We thought about bringing a community together. The UK lacked some kind of forum where innovators, VCs, startups, healthcare systems could come and talk to one another to understand better and change the language of healthcare to become more digital, more technology focused, and to be more inspiring with vision. So that's kind of where we've been for a while. Are we good? Oh, the clicker. Good. So we had the presentation, and that will start in a minute or so. So look, I want to thank you for coming, first of all, for at least bearing the cold weather outside, the restrictions around COVID, the new variant coming, of course. So I would urge you to keep your masks on as much as possible, just to make sure everyone's safe in this environment. As a surgeon, I have to make sure that I'm accountable at Giant to ensure medical care is appropriate and that we take precaution. And that's kind of my role here. So please do as best you can to stay safe during the next couple of days. And do also go down and see the sponsors, the startups. There's amazing equipment downstairs I'm playing around with. There's a HoloLens and the kind of immersive technology from Insight and Microsoft in the bottom corner. A lot of early startups with their technologies that you can play around with. So do go and speak to them. They've taken time out to share their ideas to the wider community. I think we're ready to go. So it gives great pleasure to announce our next speaker. It's Alistair Thong, who's from BIOS, who's really, I guess, inspire us about this new technology. I'm really looking forward to it, Alistair. No pressure, of course.
Well,
Right?
thank you so much for the introduction. And again, looking forward to telling you a bit about this as well. Pleasure to meet everyone today. My name's Alistair. I'm the Business and Corporate Development Lead at BIOS Health. We are a neural digital therapy company, and we believe that this is the next frontier, as you can see from the slide. So today we're going to talk a bit about a number of different aspects of the company. So the first thing is a little bit about BIOS and who we are and how we developed. Secondly, I'll talk a little bit about neural and our belief as to why it's the next precision medicine frontier. Thirdly, I'm going to talk a little bit about neural digital therapies, which are the specific type of therapy that BIOS develops. And they come in a number of different shapes and sizes. And then lastly, a little bit about BIOS, our platform, and some of the partners that we work with and how we work with other people. So most fundamentally, BIOS uses AI and neural interfaces to read and write neural signals in real time. This is the core of the company, and we're able to do that because our founders span out. Well, they didn't really spin out. They they commercialized a piece of technology that whilst they were students, basically at Cambridge University, which is this neural interfacing tool right here that you can see, and it's an implantable device that allowed the company to effectively collect readable neural data. And for a little bit about who we are, we were founded in 2015. We've got about 40 staff right now, 4 bases in the world. So the first one's in Cambridge, UK, which is where the majority of the company is based. We have another preclinical base in Minnesota, which is where most of our preclinical work happens. Another one in Montreal, which is where we have a lot of the ML and AI research that we do. And the top is based out of San Francisco. We're backed by some of the world's best investors, and Y Combinator, Real Ventures in 50 years. And we're lucky enough to have some of the great research institutions and commercial partners that work with us already, and the NIH and Spark, which is the US government's neurosimulation program, NVIDIA, the NHS, and then select universities such as Cambridge, Oxford, and Mila, which is in Montreal. And really the company started, and what we do now is focus on the idea that healthcare is moving towards a more precise, personalized, seamless user experience. And this has been enabled over the last 10 to 20 years by a huge rise in consumer biotechnology and a significant drop in the costs of ascertaining and creating healthcare data. And this is really important because ultimately data enables personalization. And this, if we look at what we have on the screen here, most therapies that have been created across life sciences over the last 50 to 100 years have always been traditional therapies where they've been acting as a single bullet or a silver bullet for a condition which can broadly affect a large number of patients. And what data has enabled us to do is actually become much more stratified with patient endotypes and subtypes, and therefore allow us to have firstly targeted therapies. And a good example of this could be HER2 Herceptin, which is a cancer drug that Roche commercializes with a specific cancer biomarker, but ultimately alternative therapies, which can be extremely specific to a patient's specific subtype or endotype, and therefore have a much higher chance of having a positive response. And we talk about why data is important. It was enabled because genomics was the first breakthrough in personalized medicine. And this is something we've known for a very, very long time now, right? The genome was sequenced in the 70s, and it cost a lot of money back then, but those costs have significantly come down over the last 50 years. Reading now, you can get your genome sequenced at least with select genes, not necessarily a full genome sequence, for under $100, which is unthinkable, 20 years ago. Separately, we've been able to get to a next stage of rather than just reading, and we can start to write and manipulate and use DNA to do different things for our own purposes. And the first example of this was really in the 80s when Amgen and Genentech were founded as companies, so 2 of the largest pharma companies in the world right now. Both of them focused on creating recombinant drugs. So one was recombinant antibodies, one was recombinant proteins, and they used DNA to edit the genome of bacterial organisms or Chinese hamster cells, and in order to create these therapies. And that was really the first example of that first biologics revolution. Now, in 2021, we allude to and liken this to what we can do with DNA as programming. The idea that you can do specific gene editing now using tools like CRISPR and Cas9, and specific therapies such as gene therapies and cell therapies, which frankly were unthinkable without the 50 years of stacked knowledge about what we could do with genomics. And this isn't to say that other forms of data modalities from biochemical data are not important. So, for example, lipidomics, proteomics, metabolomics, etc. But genomics enabled all of it. Genomics was the first one that started, and everything else since then has really been off the back of it. And it's allowed us to create numerous different healthcare applications at the as you can see at the bottom. So diagnostics and companion diagnostics, prognostics, they were one of the first things that we could do, which enabled targeted therapies in turn, genome editing, and being able to take it one step further, and ultimately now directly trying to edit humans' genomes directly in vivo with gene therapies. And our belief is, okay, if data was important for biochemistry and for DNA and everything else, neural is actually the next wave in precision medicine. And there's a really simple answer why. Most biochemical data you can collect through serum or blood or other physiological means. It's only been in the last 10 years and really in our view, since BIOS was founded, that we've come up with a replicable way to read, write, and ultimately now program nervous system data. And to be clear, when we talk about this right now, we're very much focused on the peripheral nervous system. That is electrical signals coming out of your head and below your neck, basically. And specifically the neural mechanisms of organ control for organs in your body, not your brain. We'll get to the brain eventually, but it's just an incredibly difficult organ. And it's a lot easier actually to start understanding nervous system signals as they control other things in your body first. And as I've talked a little bit about before, we have an ability through our neural interface to actually read neural data and connect it and collect it and analyze it in a really meaningful way, which is how we started off as a company. We started doing preclinical experiments and collecting neural data from porcine models and from pigs. And then we back translated it to humans, and we've started building basically all of our platforms off the back of this initial data asset that was created. But now in 2021, we've started being able to write and program as well. And when we say write, what we really mean is neurostimulate back using the same waveforms or amplitudes or frequencies that the body would traditionally use to correct neural signaling. And programming in this case is actually the ability to give a specific signal for a specific neural state, which represents a specific phenotype, which can be looked at physiologically. And ultimately, that programming will enable neural digital therapies, which I'll talk a little bit more about throughout this presentation, for both molecule-based and stimulation-based, like therapies. So I've sort of used this word neuromodulation a lot without really giving any context to what it means. And I think it's important now to get across that when we talk about neuromodulation, neuromodulation is the alteration of nerve activity by delivering electrical stimulation directly to a target area. And those target areas could be nerve centers, so the vagus nerve or the baroreceptors. It could be directly into your brain. It could be into non-responsive nerve centers, like you would do to, for example, stimulate muscle movement. But most fundamentally, it's using electrophysiology and action potential to signal rather than using biochemistry. And this is not a new area, right? Like there are many approved neurostimulation therapies on the market selling well with numerous different devices that deliver them. However, that's not to say that it's a perfect area, and that's not even to say that we're anywhere close to where we would be with even drug development with neurostimulation. And many of our partners and some of the other people that we speak to in the industry, these are the quotes that we hear. It's very much trial and error, because a lot of the time, the signals that you're getting out from the brainstem and which are looking at organ control, they don't really come in the context of anything else. You don't really look at the biochemistry. You don't look at a lot of other stuff a lot of the time. And it's very difficult to have a total understanding of the system when you understand something so specifically. As a result of this, a lot of our partners are finding that they're lagging behind and missing milestones, and it's having a serious impact on their groups. And as a result of it, they're realizing now that they underestimate the complexity of setting up software and hardware with a neural interfacing system to try and make this a replicable, way of creating a therapeutic. And as an example, traditionally in drug development, you would do a lot of your early work in rats and mice on preclinical models. And that's because they're a good biological system. They're pretty scale-upable to humans and everything. However, in a bioelectronic development and when you're developing neurostimulation therapeutics, you actually can't do that. The reason is the physical size of the nerve endings for any of these small rodents or animals is fundamentally different compared to large animals, and therefore the biophysics and the electrophysics changes due to the physical size of these things. So you actually need to, for example, go often into larger animals much quicker than you would into smaller animals, and it changes the way that our partners and other people think about developing, therapeutics in this space effectively. And therapeutics today can really be described by the sort of incumbents in the space, such as Saluda, Setpoint, and Medtronic, who develop single neurostimulation therapeutics, often a single waveform or a single, amplitude or frequency, which is delivered for a single therapeutic benefit. And that could be in pain. Medtronic's got many of those. It could be a pacemaker as well. That also does that. Or Setpoint, for example, does gastrointestinal stuff too. But, what we've seen is that there are certain companies, particularly some of the larger pharma companies, who are taking a vision and taking a stand and actually want to get much more involved in neurostimulation as well. So as an example, IOTA Biosciences and Astellas. Astellas is a large Japanese pharma company. IOTA was a startup that was acquired by Astellas earlier this year. They create it's a nanotechnology which they're calling neural dust. It's basically micro nanoparticles which can create certain electrostimulation parameters, and they can be controlled by ultrasound to be minimally invasive. Galvani is a joint venture between GSK and Verily, which is part of the Alphabet group of companies and Google. And that they're looking at trying to do closed loop electrostimulation therapeutics for gastrointestinal disorders currently, working with, I want to say Setpoint or Salute, I can't remember which one off the top of my head. And then the last is Merck KGaA, so the German Merck, not MSD, who are working with Neuraloop and InBrain in a new collaboration, which they announced and set up a new division to do bioelectronics about 6 months ago or so. And they're again also looking at closed loop therapeutics. Now, what we do at BIOS is slightly different because whilst all of the other guys in the space that we've talked about, often they have a specific focused target biology which they're trying to push forwards and develop as a therapeutic, we are trying to be much more holistic about the space and build a platform which can actually interact and allow us to not just be sort of indirect or direct competitors with the guys above, but also be customers and clients as well, and really sort of underwrite the way that new nervous system therapeutics can be developed. And we do this, again, by reading and writing neural signals in real time, because it allows us to have a real-time biomarker which we can understand, which we can directly link to phenotype or physiology, and therefore inform us a lot more on specifically how we can impact and improve all of the other things that other people are doing, as well as push forward our own programs. And I've talked a lot about neural digital therapies without, again, really saying what they are. And the reason is because I wanted to spend a little bit of time talking about that here and now. And in its basis form, neural digital therapies are therapies that use the insights of the nervous system for better precision. And there are three sort of categories that we break that down into. The first one is a targeted molecule. And when I say a targeted molecule, what I mean is a biochemical agent or compound which affects a neural mechanism of action most fundamentally. So a good example of this is the beta blocker, which is a cardiovascular drug. The beta blocker, despite the fact that it might be a small molecule which you eat orally, it needs to be digested, metabolized, absorbed, and then only will it create the same biochemical signaling to create the actual potential charges, to stimulate and therefore affect somatropic and inotropic effects of your heart, effectively how hard and how fast your heart pumps, and your ability to modulate cardiovascular disease. And in this case, our belief is that by understanding how targeted molecules can work, we can improve the efficacy of them and show that efficacy much more specifically in the nervous system and using neural data rather than just by purely looking at biochemistry or other forms of medical data which would normally inform this. Secondly, we have molecules which can be used with a companion neural biomarker. So in this case, I'll use cardiovascular sciences again as an example because there's a good example here, which is statins. So statins are a particular form of cardiovascular drug that were developed in the 90s, mostly by Pfizer, with the torvastatin, which is designed to reduce the amount of atherosclerotic plaque buildup inside your arteries, which ultimately, when you have too much of a pressure buildup, it's what is the main cause of strokes and TIAs, which are major cardiovascular events. And statins try and reduce basically the plaque burden by allowing you to process lipids a lot better. Here it's interesting because, as I've talked about before, with a targeted molecule, we actually understand that there is a neural mechanism of control for how hard and how fast your heart would pump. Well, that in itself is actually a companion neural biomarker, because if you understand what your nervous system is doing at any point in a physiological state, particularly in a disease state with like cardiovascular disease, you know. You effectively you can see and understand in real time how much your nervous system is affecting your heart to pump, and therefore you can modulate changes. And a molecule in this case here, the idea is that you can push forward clinical development a lot easier if you've got real-time, specific, accessible biomarkers in areas like cardiovascular disease, which usually require very long outcome studies, and it's harder to prove efficacy initially. Lastly, if you take away biochemistry entirely, we want to get to a future where we can have software-delivered neural digital therapeutics. And what we mean by this is really closed-loop direct electrostimulation, whereby you're not trying to modulate biochemistry anymore. you're just simply signaling directly to the nerve center, which controls an organ, and you're correcting the nervous system signal that was incorrect previously, or you're giving a new signal which is going to be more useful or more effective. And this is to differentiate slightly from what most people understand as digital therapeutics right now. So companies like Pear Therapeutics or Achille in the US, which use gamification, for example, or digitalization of a traditionally, analog thing, which you would do in a clinic. What we do is actually use genuine software to give a specific waveform or amplitude and to stimulate a specific electric signal or electrophysiological signal to give a phenotypic effect. And it's, in our belief, the purest form of digital therapeutic that will be created. And we're lucky in that whilst we were initially concentrating a lot on cardiovascular science because there's a very, very, very strong amount of target validation for how neural mechanisms of action affect the heart, that doesn't mean that we can't be just as effective across a number of other indication areas or therapeutic areas. And we've done some work in some of these other spaces like respiratory, immunology, and metabolism, but ultimately we believe that this technology can be incredibly viable across all chronic disease, not just the areas where there's an obvious neural input. And again, I've talked a lot about the peripheral nervous system below the neck, but the dream is eventually to get into the brain. It's just that the brain is really, really complicated. And if we can prove it out for the rest of the body first, it's going to be a lot easier to get into the brain afterwards. And I've alluded to this as well throughout the talk today, but I wanted to talk a little bit about how we actually develop these things and what the platform is for our company. And the first part of it is, again, we use AI-powered software to read and write neural data at scale and do it very quickly, which enables a lot of stuff. But this in itself is possible because of this long-term implantable neural interface, which the founders of BIOS originally started the company with. But the third part, which I haven't talked really that much about at all and wanted to sort of highlight now, is that we also separately have remote monitoring capabilities. And when we say that, what we mean is we use wearables, so things like Apple Watches or Fitbits or iPhones or other forms of clinical data or observational data, which you can collect for relatively low cost from consumer-grade devices, basically. We're using that in humans right now to back translate and allow us to try and improve our neural models. In the same way that, were we to collect neural data from our preclinical models in pigs, we would try and translate it to see what the physiological outcomes would be. We can take physiological data from humans and try and guess what that neural data was going to be at the same time, and effectively improve those models, push them forwards further, and continue to iterate. But it's also the area in remote monitoring that at the moment we probably have the most external interaction. So we've got a number of different partners with the NHS, the Ministry of Defence, and a number of small to medium businesses to push this forwards with numerous different patient sets. And frankly, that's something as well I wanted to put to the audience today. If there's anyone whose businesses feel that they could be interested in working with us in remote monitoring or otherwise, we'd be delighted to come and have a chat afterwards. And to reiterate as well on some of the reason why our platform is advantageous and why it's interesting, it allows us to create novel, more precise therapies is the first part of it. So I've talked a little bit about how, we can interact across biochemistry and how that can actually improve the clinical development timelines and potentially preclinical development timelines as well as potentially find new drug targets, frankly, which could be neurally modulated, which is great. This also leads to higher preclinical and clinical translation success rates. So our belief is that by having a much more specific, very, very, very detailed understanding of what neural biomarkers look like, it's going to be much easier to convince regulators as well as internal, actors, basically, who have a specific position about moving between stages, that there is something grounded in science and reality as opposed to just taking a guess with the next trial that will be run. Which, to be honest, within cardiovascular science is one of the really big challenges at the moment, is how to lower the cost and improve the success rates. And we believe that we can be a significant part of that. We believe as a result of this, we're going to accelerate discovery and development of new therapeutics. And whether those therapeutics are biochemical or whether they're neurostimulation therapeutics and software derived, it doesn't really matter because the view here is to help with chronic disease. And ultimately, all of these three things enables continually improving the closed loop AI system to make it better over time. So the more we do of each of these things, the more the system is going to get better, the better the insights are going to be, the more specific they're going to be, and ultimately the more impact that we can have across chronic disease. And, you know, I've talked a little bit about this as well, but we partner with lots of different types of actors. At the moment, we're heavily focused on partnering with pharmaceutical companies, mostly around the molecule-based neural digital therapies that I mentioned today. So the idea of helping pharma companies push forwards their own biochemical assets, which they've developed up to a certain point. But you know, some pharma companies are also interested in doing direct neurostimulation themselves, and ultimately, to get to that future, they recognize that our platform is a great way to do it. We're also working with healthcare systems and trying to improve the way that biomarkers, particularly neural biomarkers, can be used to assess different aspects of health insurance, and life insurance as well as the other thing, which is useful for this. And you know, part of that is to make sure that the biomarkers that we're developing get broad acceptance across the industry, not just within specific aspects of it, but also because ultimately we want to get to a future where we change the paradigm as to how these technologies get adopted. If we don't interact with these guys early, it's going to be serious problems later on. Neuromodulation companies as well. So I talked a little bit about some of them earlier, but specifically we can help them with two things. Number one is calibrating the therapies that they currently deliver via their devices better. So oftentimes when you get an implantable device right now, whether it's a pain stimulator for your spinal cord or a pacemaker, they're only really calibrated at the point of surgery. So when the patient is on the operating table and they're getting the device put in, and then it will stay like that until the next surgery or the next time they have to get something altered for it, which could be months at a time. And your body obviously moves a lot quicker than that. It might find that the simulation that's happening is not enough after the first month, but there's no way to actually change that without having a significant amount of invasive surgery for the most part. So our belief is that if we can help these companies calibrate these devices better at the point of surgery, or alternatively calibrate them better out of surgery, we can really change the way in which they can interact with patients and all the rest of it. And then lastly, academics and researchers, which is a bit more broad. I work with a load of different academic groups looking at both neurostimulation targets, but also for all aspects of the business, whether that's electrical engineering and edge processing for our tools, or whether that's tissue engineering, or all sorts of different aspects. And we're very open to partnerships. And the first area we're targeting, which will be unsurprising to everyone here now that I've been harping on about it for so long, is heart disease. And we're doing this via what we call our autonomic therapy initiative, working with all the partners that you see below. And the idea here is really we're trying to create a therapeutic to replace the beta blocker as a neural mechanism of action, and something which is very well understood. We believe that can be a very impactful first place for us to interact to build our own therapy. So really, in terms of key takeaways, what I really wanted to get across to everyone today is that our belief is that neural is the next frontier in precision medicine, and ultimately medicine as a whole. We believe that as a data modality, it's the most underserved right now, but it's also something with a huge amount of fidelity and information that comes through. Secondly, neurodigital therapies are more precise, and they'll enable the people and patients to have a much more stratified and powerful treatment, which could eventually be disease modifying and hopefully curative if we get to that future. And lastly, our neural platform is open for partnering. So if there's anyone in the audience today or listening online who feels that what we're talking about could be interesting, do reach out. We're really keen to have a chat and see how we can grow and build. And yeah, aside from myself, Patrick, Annie, and Emma, who are there and at the back, we're all going to be around today, and would love to interact and have a chat with anyone who's interested. Thank you so much for the time today.
Thank you. Thanks, Alistair. That was an amazing journey to the future, right? And it sounds really exciting. Quick question from me. How far are we away from seeing a first product that's working? Can you share that?
So it depends what you mean by the first product that's working, but I think we'll intend to be in the clinic, hopefully either end of this year or next year, if we can get it right. And yeah, hopefully we'll have some biomarkers as the first product, as a starting point to get to that closed loop electric biopharmaceutical future. That's still a bit of a way away. We won't pretend, but of course, it's coming in stages. And the first stage will probably be just creating and modulating those biomarkers so that we can use them to get to that future.
Look forward to seeing that journey. Alistair, thank you so much for joining us. Okay, so now we're going to go back into kind of virtual hybrid world. I think hopefully Tobias is waiting for us in Germany somewhere. Can we put him on? Tobias, can you hear us? Can you hear us? Can we have the audio?
Yes, I can hear you well.
Tobias, can you hear us? Yeah. Can we, is the audio on? Sorry?
Yeah.
Oh, he's interconnection. Oh, that's Germany. I thought they were supposed to be real techie in Germany, right? No? I got it wrong. Okay. Tobias, can you hear me? We've always wanted to say, you're on mute, right? Those famous 3 words, but let's see. Can we get him, can we text him or just get in contact with him?
Yes, I can hear you.
You can hear me, Tobias. That's great. Tobias, thanks for joining us. This is Tobias Silberzahn, who's a friend and colleague of ours, and McKinsey is our knowledge partner for Giant. They've been very supportive of us over the last year or so. And he has a huge interest in digital therapeutics. I think he has like 800 companies or more now, I think, who are now part of the kind of McKinsey support to improve digital therapeutics and access to healthcare systems. He's going to be talking to us about the emergence of healthcare systems. And so, Tobias, if you can hear me and you're ready, carry on. And I understand you want to do a Q&A at the end for the audience. Is that right? We'll let you carry on, Tobias. Off you go. Tobias, can you hear us? We're ready to go, Tobias. Can you connect with him on the computer? Are you talking to him? Just say he can go. So as soon as he's ready, we can start. And I won't say schnell, schnell, schnell. We can just get going. It's quicker on later. Oh, good. We've got something.
Great. Nice to be. Nice.
Okay. All right. I'll carry on. So we're having issues around internet connectivity. So we'll give it a minute to see whether we can improve that for him.
Okay. Will I?
Can he hear you on the computer? You have a good connection there. So, yeah, refresh the feed. Let's see if it works. Absolutely. Yeah, we're good. All right, Tobias.
Now?
Can we hear you? Can you hear us now? Excellent, Tobias. It seems that we've corrected. Tobias, the floor is yours. Off you go. Good to see you, by the way.
Thank you very much. And thanks for having me. Great to see you again, Shafi. And yeah, I would love to be with you in person. But due to our COVID pandemic, I need to do it virtually. So my thoughts are with you in London. I'm Tobias. I'm a partner at McKinsey in Berlin. My focus is on digital health, business building, and scaling. And I do that kind of work both with young companies like startups and scale-ups, as well as in the corporate business building space. And as Shafi mentioned on the side, I lead what we call the Global Health Tech Network and CEO Roundtable, which is a community of a bit more than 1,000 digital health and health tech companies. And I will sort of sprinkle in some of that experience during the talk now. I'll talk about 3 things: a quick introduction to ecosystems, secondly, then focusing on digital health ecosystems, and finally, a bit around digital health business building in the ecosystem space. And so ecosystems, a lot of people use that word now for this talk, and when I use it, I think about it as interconnected sets of services through which users then can fulfill some of their needs in one integrated experience. And initially, of course, we had lots of individual offers in many different industries, and now by customer trends, by technology advancements, this is now increasingly integrating into multi-product, cross-sectorial propositions that we would call ecosystems. Ecosystems are not new, right? This is the ecosystem framework from Walt Disney in the year 1957. So there's the thinking has been around quite a bit. But today, really, with the technological advances in the platform economy, the ecosystem economy is taking off. So this is a simplified view of the ecosystem economy, forecasted to be about $70 trillion by the year 2030, and consisting mainly of 12 different ecosystems, of which health is one ecosystem. When we look at sort of needs and different settings of life, there are then several ecosystems also that span different sectors. For example, the elderly ecosystem that includes housing, mobility, health, or then the family ecosystem, or the agriculture ecosystem, city ecosystem, etc. What those ecosystems have in common is that they create value via integrated customer journeys, be it in the housing space, be it in the elderly space, being in the health space. And when we look across different industries, we see ecosystem offerings popping up pretty much in every industry. What can we say about the ecosystem economy so far? But do we have proof that industry players across all sectors have been able to value propositions? There, I would say yes. We've seen more than 800 ecosystem offerings across all industries and sectors. Do we have proof that these end-to-end customer journeys create real measurable impact for businesses? I would say that one is also yes. In almost every sector, we can see that ecosystem strategies can have commercial benefit, customer benefit, profitability effects, market share effects. Then do we have proof that companies not adopting ecosystem strategies are getting disintermediated? I would say we've seen quite a few case examples where ecosystem orchestrators have profoundly changed the industry landscape, and some of the non-ecosystem players have been disintermediated through that. Then if we look at, can companies go beyond the pure business impact and really change their business model overall? There, I would say we've seen a few case examples where this has happened, but not for everyone. And then whether ecosystem players can create and outperform the other companies sustainably. There, I would say this remains to be seen, right? Currently, ecosystem players often have quite a lot higher valuations than non-ecosystem players, but this is not the case that across all sectors. Right, and there is also a difference between correlation and causation, right? A lot of the ecosystem players are generally very innovative companies, and so in that sense, one couldn't, let's say, one cannot causally attribute that effect yet. So now, moving towards digital health ecosystems, and as a biochemist and immunologist, that's what I'm most excited about. And leading a health and well-being program in the employer space myself, I'm quite interested about digital health and ecosystems because I feel that there is a potential to help citizens, help employees, and help patients sustainably change their behavior. And as you can see here on this page, 30 to 50% of health outcomes are behavior influenced and behavior driven. So quite a large part of patient outcomes are behavior driven. So if we then think about digital health ecosystems, they enable personalized patient journeys. They connect different existing digital health applications. Ideally, they have then a convenient, seamless user experience. There's often then also data behind it that then can inform and make these customer experience more convenient. and it can help navigate customers and citizens and patients through the ecosystem. So if we now look purely in healthcare, we see mainly 6 different types of ecosystems emerging in the health space. There are the upper left primary care plus pharmacy ecosystems, where it often starts with a digital pharmacy offering and then goes into telemedicine, chronic disease management, etc. Then there is the middle archetype. This often starts in the insurance space, like with Ping An, that I will talk about in a bit more detail in a minute, and then goes into primary care. We also see sort of combinations of primary care and secondary care ecosystems, where Teladoc and Livongo, I guess, are a good example with a recent merger. Then number 4, we see quite a bit of home care, smart home, smart health ecosystems emerging. That's often with voice assistants helping people stay in their homes for longer. Then very nascent, we see precision medicine, genomics-based ecosystems emerging, and there in the US there have been quite a few acquisitions in the last couple of weeks. And then there are also B2B digital health ecosystems in the clinical trial space, in the health data space, etc. The interesting part about these different archetypes of ecosystems is that when we look at it across the globe, we see more than 50 ecosystems emerging, and they are led by different types of organizations, right? As you've already heard on the last slide, some of them are payer-led, some of them are provider-led, others are led by health tech companies, others are led by medtech companies, some pharma companies are in the space, pharmacy-led, and also some tech companies and mobile phone companies, interestingly. And when we look at that in Europe and when we look at it in the US, then some of the scaling is in its infancy. But today I want to talk a little bit about what we see happening in Asia with digital health ecosystems, where scaling has already happened to quite some degree. So the largest ecosystems in Asia have between 300 and 400 million end customers within the ecosystem, and they are quite rapidly growing. So if we look at some of those ecosystems, and we start with the Ping An ecosystem example, that is an interesting ecosystem from my perspective because it includes several online offerings like appointment booking, e-prescriptions, telemedicine, and it goes via the Good Doctor platform, as Ping An calls it. And they also have quite a lot of offline services that are in the ecosystem as well. And when we look at it from an entity perspective, there are 12 different entities part of the Ping An ecosystem, right? They range from patients, providers, payers, also life insurance, research institutions, investment vehicles, etc. So in that sense, it's one of the most scaled and also the most complex ecosystem that has been years in the making. And if we now look more towards a provider-driven ecosystem, there is currently the Apollo ecosystem being built in India. And I believe that's also an interesting ecosystem because it includes brick and mortar kind of assets that Apollo has had over and has built over the decades, like more than 70 hospitals, 2,500 plus pharmacies, 500 diagnostic labs, and they are now building a digital health ecosystem around them. So then doctor telemedicine appointments that you can speak with a doctor virtually within 15 minutes, medicine at home delivery within 2 hours, that of course then builds on the pharmacy backbone, then disease management offerings, health records at the back of it, and diagnostic offerings, which is one of the most, I would say, also looking at the US, hottest areas of digital health ecosystems right now, diagnostics at home, remote diagnostics. So if we look at that, what that looks like in terms of stock market effect, total return to shareholders. Here you can see an overview with different healthcare conglomerates and healthcare companies in Asia, with Apollo being executing their ecosystem strategy as of the year 2020-ish. And you can see quite a bit of an increase. And if you would, I looked it up just a few days ago, if you look how it has developed from March 2021, which is the end of this graph, towards now November 2021, it almost doubled again. And it's actually interesting to see, right, how an ecosystem strategy is leads also to a perception appreciation at the stock exchange. So to now also think about what can we actually learn from some of those digital health ecosystems, and what are some questions to keep in mind when you might be a health tech company, you might lead a digital health company, you might be a digital health leader of a pharma company, medtech company. Some of the questions when I do ecosystem strategy work that I find useful to think about is are listed here. Right, a lot around what are the assets that one brings to the table, right, and what is the competitive advantage that one can build on, but also secondly, what is the role that one wants to play in an ecosystem. So if we, for example, take that question quickly, right, there is a role of the ecosystem orchestrator that you can see on the left. Right, and that enables additional customer touch points for you. If you orchestrate an ecosystem, you can add new services along the value chain. You generally have something like a 360-degree view of customer data, but it also requires significant effort and investment. Then if you are an ecosystem participant on the right, you can offer some new touch points via the ecosystem. You can use the ecosystem to scale your offering, right? And you can be part in someone else's ecosystem to get access to installed base, expand your geographic reach, etc. When we speak with the digital health ecosystem leaders and builders, the ones who have been building ecosystems over the past years, and we ask them, what are the main success factors for the customer? Then it comes up, convenience is the main factor that has come out from ecosystem business building. And of course, then this is a map of how a digital health ecosystem can look like from one of the projects that I've been leading in that space. Then the question often becomes, when we are clear what kind of role we want to play in an ecosystem, right? What does that ecosystem look like, and what are the offerings that we actually bring to the table? So here, and this is a simplified ecosystem map, right? But in essence, you could think then about having 20, 30, 40 different offers. And then the question is, what offers do you need to, for example, delight your customers, create a convenient experience? And then when you are clear what offerings are, right, some of them are revenue generating, others are not revenue generating, then the question often becomes, what are the ones that you build yourself? What are the ones where you partner? What are the ones that you do M&A? Then another question that often comes up when there is a digital health ecosystems being built, right? Are people using sort of the super app approach that is quite popular in some other industries, or is it more of a string of pearls approach where a user is moving along a chain? Right, the digital health ecosystem builders that we've interviewed, 2/3 of them favor the string of pearls approach. Then in terms of implementation, and this is now mainly the question also for corporates who are building ecosystems like medical device companies, mobile phone companies, pharma companies. But the key success factors that have come out from the ones that have already built digital health ecosystems over the years: strategic direction and the culture, moving fast, moving quickly versus the traditional corporate mindset in healthcare. And that brings me to the end of that short presentation, and with the question, what will your role be in the healthcare ecosystem, right? Do you see yourselves more as an ecosystem participant, as an ecosystem orchestrator, etc.? So if you want to know more, or if you are interested in the health tech network that Shafi mentioned, here you can see how you get in touch. I guess the easiest would be via LinkedIn. And with that, I say thank you for having me, and I wish you a great conference.
Everyone, Tobias, thank you so much. Can you hear me?
Yes.
Wonderful, great presentation. I took lots of notes, lots to learn from. That's huge experience of understanding different healthcare systems across the world. So thank you for sharing your years of experience and your insights, which I think are unique in terms of healthcare, Tobias. So thank you so much for that. We've got time for Q&A, about 10 minutes or so. So as you think about questions, Jay will run around with a microphone. So please feel free to ask Tobias some questions. So Tobias, my question to you is, we talk about here about the innovators, companies in digital therapeutics and others who are trying to influence healthcare systems. What's your advice in kind of working with so many companies and supporting them through their kind of journey, I guess, into health? Can you share some insights with us?
Yeah, I guess one dimension here is the customer angle, right? Very much thinking across customer segments, what customer segments to focus on, right? And these can be in the health and well-being space, right? Like young families, students, or they can be in the chronic disease management space, right? Like dealing with chronic disease patient, cardiology, oncology, etc. And being very clear initially, what is the segments that you are focusing on and what do you want to achieve in the segment? For example, from one of the ecosystem strategies that I had the pleasure to work with, there the objective was we would like to support 9 out of 10 related health touch points that this customer segment has over the course of a year, right? And then based on that, we were then building the ecosystem accordingly. I think the other point, Shafi, and that is particularly for incumbents that are thinking about digital health ecosystems like medtech companies, health insurances, hospitals, or also pharma companies, then the question is, what is the asset that you really bring to the table? Right, and I now frame it a bit provocatively, right? Sometimes it's not so clear what is the asset that the company brings to the table, and then that is, of course, then an inherent weakness of the digital health ecosystem if you don't bring a strong asset with you, right? And strong assets can be a digital pharmacy. It can be a large cyber base for a mobile phone company, right? Who has 5 million, 10 million, 15 million subscribers. That is what I mean with assets that you can build your ecosystem on.
Thank you for that. Any questions from the audience? Feel free to raise your hands and Jay will come round with you. Great chance to interrogate Tobias, who's got amazing knowledge of all this. Yes.
Hello. Hi, Tobias. One question, with all the companies that you're working in terms of building their digital technology, are you finding a percentage that they like to build from within and build their own, or is it that they like to partner and perhaps add on technologies either through licenses or through partnerships?
Yeah, a great question. And it depends also a bit on the mindset of the ecosystem that you are dealing with, right? So if I come back to the 2 case examples that I mentioned, the Ping An ecosystem has actually an investment vehicle, right? The Ping An Corporate Voyager Fund, and they've actually made more than 100 investments, as far as I know, into different health tech companies. And often those investments are also incorporating a partnership where then they would partner with a European health tech company to then bring that company into their ecosystem, right? And other digital health ecosystems, they are more in the mindset of building things themselves. And the third interesting component is what I've seen with some of the European ecosystems who are also thinking about platform as a service offerings, right? So that then the ecosystem contains a digital tech platform in essence, and then the ecosystem orchestrator makes the tech platform available to other companies to host their digital services, right? Be it a patient companion app or a digital therapeutics app, etc. Right? So in short, partnerships is an incredibly important topic, right? Because at the end of the day, you can have 20, 30, 40 different offerings as part of a broad digital health ecosystem. And the answer is usually that it will be a mix of building some yourself, then partnering with some, and then also acquiring some.
Okay, thank you. Another question at the front. While waiting for that question, Tobias, I'm going to put you on the spot. Who's got the best healthcare system, in your opinion, now that you've seen all of them over the world? Did you hear me, Tobias? Have we lost connection? Okay, so what should we do?
You mean health system on a country level?
Tobias, can you hear me? Oh, okay. Do you want to reboot quickly? Because it worked last time. Tobias, we're just going to reboot very quickly because we're losing your audio quality. Give me 1 second. And you can be ready. Okay, Tobias, I think we're back. Can you hear me?
Just reconnected.
Perfect, perfect. So we just have some issues around connectivity here, so thanks for being patient with us. Before we go to the audience, I was asking the question, given your expertise and your presentation healthcare ecosystems, in your mind, who's got the best healthcare system at the moment?
You mean healthcare system on a country level?
Yeah, at a country level, yeah. Who do you think we should aspire to?
Well, and thanks for asking the question. It's fascinating how health systems evolve. If I can give you one example, I love how Denmark is thinking about precision medicine. They, in essence, been thinking about how to make precision medicines available to population, both in the trace. And out of that, they've been building sequencing labs, building supercomputers, biobanks, clinical decision support, so that then in the next couple of years, Danish citizens can have genomics-based personalized medicine. And that is an example where then, real target state thinking and then bringing it back to how to then build what they call a national genomic center can actually be a really nice path to then think how digital health and genomics and traditional medicine comes together.
That's great. And Denmark is one of the happiest countries in the world. So they may be linked, I reckon, Tobias. Is that right? Look after people's health, they're happier. It makes sense to me. Question from here. Thank you. Just talk. It's okay? It's on. They'll turn it on.
Hello.
Yep.
Okay, that works. Hi, Tobias. My question is around sort of thinking about indication or specific therapy-centered ecosystems. Do you think that's potentially too niche to be valuable, and instead companies should focus on creating more holistic solutions?
Yeah, great. Thank you. I think that when I look at some of the ecosystems out there, right, be it a provider-driven ecosystem or an insurance-driven ecosystem, they will have disease-specific offerings, and they will have health and well-being related offerings related to sleep, nutrition, fitness, and stress management. So in that sense, the disease-specific offerings might be indeed something based on what we discussed in in one of the earlier questions, right, where a disease-specific offering is being offered via a partnership model, right? And then the ecosystem orchestrator hosts the overall ecosystem, right? In the Ping An example, having the contact to those 350 million end customer, but then the disease-specific offerings come in via a partnership model.
Okay, that's helpful. Good, thank you. Any other questions? We've got perhaps another a minute or so to go. Now, I was going to ask you about you've got Aura Ring, have you? You're wearing an Aura Ring, I saw. Is that right? Tell me, do you know about the Aura Ring? Yeah, so have you found it useful, Tobias?
Yeah, so maybe I should also say I lead our own health and well-being program for our 3,500 employees in Germany and Austria. And as part of that, we are thinking about what are the offerings related to sleep, nutrition, fitness, stress management that we would like to offer to our employees, right? And that has a wearables component, that has a health coaching component, that has a digital app component. But I personally, as I could say I'm our primary guinea pig, and I take great pleasure in that since I have some biohacking tendencies. I love the integrated offerings that are bringing sleep, nutrition, fitness, stress management all together. And there I find it useful to have that then helps me. It's a bit like the display in a car, right? Knowing how much I slept and knowing how well I do, it often means that I might, but not always, behave in a more sustainable and sensible way.
Brilliant. So I think we should change the title from Partner McKinsey to Biohacker, as well as being a partner McKinsey. Tobias, I want to thank you. I think you always share some wonderful insights. Really, I look forward to your talks because your experience of healthcare around the world, what you're building is truly inspirational for all of us. So a fantastic talk for us. Thank you so much, Tobias, for joining us from Berlin, taking time out, supporting the partnership with Giant. We're ever so grateful. So big round of applause for Tobias Silberzahn.
Thanks for having me, and thanks for sticking with me despite the slow connection.
Not at all. You're fantastic.
Have
Tobias,
a great conference.
We'll speak soon. Bye-bye, Tobias. Bye-bye. Okay. What's the name of the person? We're going to be covering different sessions, different areas of interest for healthcare. And again, it'll be a mixture of live face-to-face, some hybrid, and some panel discussions. So it should be a very interesting and exciting afternoon for all of us. The first one's going to be like a fireside chat, but hybrid. So it'll be me and somebody. Hopefully they'll appear on the screen fairly shortly. And I think we've got Chris afterwards speaking. Can we get Charlotte online if it's possible? Look at that, the miracle of technology. Immediate. Charlotte, can you hear me first and foremost? We can't hear you, Charlotte. No, we can't. Just give us a second. It'll be fine, don't worry, okay?
That's all right.
With people in two places. Charlotte, thanks for joining us, number one. It's always a pleasure to have people, of course, join us on Giant. Can you tell us where are you at the moment?
I am in London. You can probably tell from the very tropical looking background that I'm enjoying the weather.
No, sure. Thanks for joining us. Charlotte, we have an audience here, and I think it'd be first just to get your background, to get some details about who you are, and a bit more about Big Health, if you can.
Yeah, of course. I mean, nice. It's amazing to be here. Thank you so much to Giant for inviting me. My name is Dr. Charlotte Lee. I'm the UK Director for Big Health, and we're a digital therapeutics company in mental health. I guess in terms of my background, I speak 3 languages. So I speak medicine. I trained as a doctor in the NHS and became a Darcy Fellow. I speak the world of healthcare management. So I spent some time in management consulting, really looking to support organisations in complex change really in the NHS. And finally, I speak the world of digital health, which is my sort of new career, I guess. I spent some time with the academic health science networks, supporting about 100 or so small to medium-sized enterprises to expand in the NHS. And I've been with Big Health now for about just over 2.5 years. You asked about Big Health, and I'm glad that you did. So some of you may know about Big Health, some of you may not. Many of you may know one of our products, Sleepio, which is a digital therapeutic for insomnia. And Big Health really is a company dedicated to developing software with really high quality clinical evidence behind it to show that this software can treat common mental health conditions. I mentioned Sleepio, so that was our first product. We were built sort of 10 years ago, and Sleepio since inception has 12 randomized controlled trials showing effectiveness in treating insomnia as well as in mitigating for other common mental health conditions like anxiety and depression. And recently in 2020, we launched Daylight for anxiety. So that's our digital therapeutic for anxiety. And its first RCT showed 71% remission for moderate to severe generalized anxiety disorder, which is really fantastic. So that's us. We're Big Health. We're kind of like a mix between pharma, biotech, and SaaS, really.
And mental health is your main interest with that whole platform?
Yeah, at the moment, our mission is to help millions back to good mental health. And we're doing that currently with our 2 products, Sleepio and Daylight.
Which is amazing, of course, because mental health has been one of those kind of forgotten parts of our healthcare system, and we need to support that. So I'm glad that that's been your main priority. Excuse me while I got a bit of cough this morning. You've recently announced a partnership with the Scottish Government. Can you tell us a bit more about that, what that means?
Yeah. So our expanded relationship with the Scottish Government means that Scotland is the first country in the world to make digital therapeutics available, reimbursed nationally for all adults, which is really, really amazing. How did it come about, you might ask? Well, first of all, it takes 2 to tango. And before I go into the story of how all of that came about, I just really wanted to give a huge shout out really to the Scottish Government for thinking big and adopting digital therapeutics. I know it can be really challenging to innovate in a complex, organisation like the NHS. But they are genuinely stand out, in my opinion. And, if there's one message that innovators can take from this fireside chat, it's that, the Scottish Government are a fantastic partner. And if you want to, partner with an organisation or a body or a government, for example, that are really forward-thinking, innovative, and willing to take on risks, I would really highly recommend the Scottish Government for that.
And so the next question, of course, is that around that tariff that you mentioned, because we had a discussion this morning about remuneration models, tariff, different ways that healthcare systems work. So that's a real forward step in thinking on how you remunerate or make those new technologies like digital therapeutics viable, right? So what are your thoughts around that? And how did the Scottish Government go about developing tariff models around innovation?
Well, that's a tricky question. I wish my counterpart in the Scottish Government was here with me. he definitely has far more experience in designing these tariffs. So, to be honest, we don't have the perfect solution. From the digital therapeutics perspective, well, as I said before, we're kind of like pharma. So for every license, you expect to pay a certain amount, and you get prescribed or made available across that particular population. But that doesn't necessarily always work out for the NHS. And I know that the NHS at the moment is innovating quite a bit with different payment models. For example, I remember reading recently that for antibiotics, they're going to consider a Netflix style subscription, where for a fixed price, they get unlimited access to these drugs. And that's, also certainly another, payment option that could be explored. But I think a really innovative and exciting thing about this is that we've always wanted to go towards outcomes-based commissioning, but we really struggled to do it, partly because it's really hard to do. We don't have the data to work out whether someone has used a drug, for example, whether they have recovered. And so without that data, and also the complexity in administering all of that, the NHS has really fallen on, well, what is the simplest model that we can understand and to budget for? Whereas I think, now that we're moving into a world and to budget for. Whereas I think, now that we're moving into a world with digital therapeutics integrating into electronic patient records and, a place becoming far more digitally enabled, I think that availability of data across, a patient's lifetime is going to be really exciting in terms of helping those more innovative payment models to evolve.
Yeah, thanks for that. It is a difficult dilemma going forward, and as you just say, there's no perfect solution, but hopefully at some point we'll be able to think about new models of reimbursement, as you've suggested. Tell me more about your actual product and your platform. How does it work? Can you share some tidbits on that for us?
Yeah, sure. So it's not groundbreaking stuff. That might be crazy for someone speaking from a technology standpoint to say. If I start off with Sleepio, it's a really simple web-based program. You get given a link, you go on, and you do your initial sleep test. So it tells you how bad your sleep is and suggests some initial, articles or resources for support. Then you can go straight into the CBT for Insomnia program. So it's meant to mimic what you would experience if you're going to see a therapist face-to-face. So you have 6 weeks of 20-minute sessions with an animated prof and his narcoleptic dog, Pavlov, and they take you through a series of different exercises that you can learn and apply to your day-to-day life that help you and are evidence-based to help you to improve your sleep. The difference here is that you can get this anytime you want. You can go onto it at 3 a.m, and it's like being in front of a therapist. Plus, you've got the benefits of all of the other resources around it, as well as a community of other patients and people using Sleepio. So it genuinely is, a 24/7 kind of solution where you can get access instantly. Similarly, we have Daylight, which is a program for anxiety. And the way that Daylight and Sleepio work together is that you have a 24/7 night and day solution for mental health. So if you need something that helps you just to decompress during the day, you've had, let's say, a very stressful, fireside chat, and you can't see anyone on the screen, and you're just, you're having a bit of a meltdown. You go onto the app, and you can go into an evidence-based CBT resource. It goes through the exercise right there and then with you with an animated character, and it's very, very engaging. So you can decompress and help relax right there and then. I'm going to pause there. Does that make sense?
Yeah, no, that makes sense. And I'm now almost in my end of 3rd decade as a doctor, so I'm sure I could have used some of these technologies in the past to get through some stressful times, difficult times that we all face as doctors and healthcare workers. I'm glad that you're addressing a fundamental problem that is now become more well recognized for healthcare workers who've experienced these things. you're not only working in Scotland, of course. I think you're also working in England in various parts. Can you tell me about what you've been doing in England in terms of your platform, who's been accessing it? Give us more information.
Yeah, definitely. So, as I alluded to before, we give unlimited mental health treatment night or day, no prescription required. And the thing in England is that, despite being evidence-based, NICE recommended, CBT for common mental health conditions like insomnia, like anxiety, are just not readily available to the GP in a timely way. And, Shafi, you and I have probably experienced this in our time as a clinician. We're reliant on drugs, to be very honest with you. As a foundation year doctor, I can't remember the number of times that I prescribed Zopiclone for someone to go home with. But we know that they're not a long-term or safe solution. However, referral to mental health services, the gold standard, ideal, right? It can take 6 weeks or longer to see someone, and it can take even longer than that to get outcomes. And in fact, I remember speaking to a GP and him saying, 1 in 3 patients I'm seeing are coming to me about their poor mental health. And so without options in that GP's toolbox for evidence-based treatment, managing mental health demand feels impossible. So we're working, as you can probably tell, with a number of primary care organisations in England, and through digital therapeutics, we allow primary care to offer access to first-line clinically proven treatment. And it doesn't have to be through a GP. So we've shown as well through draft NICE guidance that Sleepio is clinically and cost-effective, that Daylight is already miles ahead of other products with its first RCT, and primary care is adopting it. I remember one GP saying to me that this meant that their team could prescribe high-quality treatment to a patient instantly, digitally as well, and see outcomes in as little as 6 weeks.
And so can you give us an idea about how many patients are now benefiting from your platform? Can you give an idea of where you are at the moment?
So I think overall, the number is upwards of 100,000 patients already. These aren't just registrations onto the program. We are actually looking at counting the numbers of patients actually in therapy, so in CBT, and actively engaging with it.
And is CBT done automatically through digital components, or is it a face-to-face live? How are you organising that? Because that's going to be the barrier, I guess, to the amount of scale-up you can have.
Yeah, absolutely. And this is where digital therapeutics comes into its own. Digital therapeutics don't necessarily need to have a clinician in the process of delivering that treatment or that therapy to a patient. It is fully automated, but it's not meant to replace the clinician. It's meant to increase capacity. And I talked a bit about pharma and biotech before. Digital therapeutics is genuinely a new treatment modality that's being offered to patients right now in Scotland and also in parts of England, where you get the full package of CBT. That specific program has been through a number of randomized controlled trials itself, so it's not based on face-to-face CBT clinical evidence. It's actually been placebo-controlled and been through the robust process to show that it is clinically effective, kind of like a drug, and so that it can be delivered within the NHS and within clinical services safely. So if in a nutshell, it is completely standalone automated treatment.
You mentioned a bit about trials and evidence, and you're very keen as a company to promote that and to find real evidence for that. Can you share those insights, how you've gone about getting the evidence required to validate your model? Because that's often a missing link. A lot of digital technologies don't have access to clinical trials, and that's been a problem for them.
Yeah, absolutely. And, this is also a systemic issue that the NHS is looking at to, reduce that time from, conception to, evidence in a robust way. We were lucky, to be honest. So when Peter, our co-founder, set up the company, he partnered with a professor of sleep medicine, Professor Colin Espy. who was at the time, he had an academic post at the University of Glasgow. And Colin actually was the guy who said, look, we don't just want to create some app or some digital program that doesn't necessarily have the evidence behind it and you can just sell it direct to consumer. We're going to put it through its paces. So back in 2016, for example, Sleepio had its pivotal RCT, and I believe that was the first time that a fully automated digital solution went through an RCT. And it had really promising results. So I think we had 76% remission for insomnia. I guess, to your question around, how did we get, those resources and I guess the funding to be able to support all of these clinical trials. I'm not able to share with you, the full detail. I think Colin's probably the best person to give you that. But it was partly because we had such a strong clinical researcher as a co-founder who already brought with him 30 years of academic research and his network into scaling up a lot of the research that we needed. And when we started out, we didn't build our team with salespeople. We built our team with clinicians and researchers, like pharma, to ensure that we were able to, evidence our product and to be able to articulate that evidence clearly. I appreciate that's, for those of you who might be looking for a framework or a blueprint, I can't give it to you. But if you want more details, I'm happy to have calls with people after this.
No, you've done really well. I think as an example of a company coming onto market, thinking about the real world validation and how you then scale, which I think you've done very well with those important collaborations with NHS Scotland and other providers. NICE guidelines have recommended CBT therapy before medication, from what I understand, which is where I think you add a lot of value. So did you take that guidance before, or did you realize that was going to be the future? How did you get into that position where you are now relevant to NICE and therapies?
It's taken 10 years, Shafi. Right at the start, 10 years ago when Peter and Colin were flogging Sleepios in anywhere that they could, we were certainly not relevant. I think digital health back then was perhaps related to fingers rather than technology. So it's taken a while, but it is really exciting news, and for me, it builds on what we knew already, that drugs aren't ideal first-line treatments for mental health and that we need alternatives. And there's been a number of policy documents written, particularly in Public Health England and elsewhere around ensuring that we align with NICE guidelines in the treatment of common mental health conditions. And you're completely right, as a developer of scalable digital therapeutics using CBT, we fit directly into that need of providing CBT first line in a very cost-effective way. And, we're already doing this in Scotland where our products are available. And I guess the exciting thing is we're looking to England now around, as a follow-up to this guidance, whether they will also adopt and look at the Scottish example and start genuinely providing scalable mental health care to all.
Yeah, no, I totally agree with you. Is it okay if we get the audience to think about a question or two? Charlotte, are you okay with that? Right, so...
Yeah, absolutely, fire away.
The audience, so there is a microphone that will come around. So just raise your hands if you've got a question for Charlotte. We've got a question here at the front. Should we get a microphone, please, somebody? Thank you. Thank you, young man, for helping out. There we are. Should you just announce yourself, your name, and ask the question?
Hi, my name's Ashley. My question is about the demographic that your products serve. Do you have like a distinct bracket that you go for? And how do you approach people who maybe are a little bit less tech savvy or a bit suspicious of using tech to service or, serve their mental health?
Yeah, that's a great question. Really, really, really good question. So first of all, all of our products are relevant to across the whole demographic. We've shown through an RCT before that there weren't reduced effects in people from, lower socioeconomic backgrounds, for example. So that's one piece of it, and I know that we're just one small part of this very, very big problem. In terms of the question around how we deal with people in the population who may be less tech savvy or may be suspicious of technology, well, that's why we partner with the NHS and local organisations. So we know that as a purely digital product developer, we're not able to be there or to provide our products to those individuals. However, what we have done in the past is go local, work with organisations like libraries, charities, in GP practices, upload our products onto the webpage, for example, and ensure that for those people who may not have access to technology at home, or even just like a Wi-Fi connection that works, that they can have access to our products where they go and where they need help.
Great. Another question just here. Do we have the microphone just here? Thank you. Just the front here. That's it. Thank you.
Thank you very much for your talk. My question is relating, so kind of tangentially to your earlier point about being a remote first sort of business. How do you turn that from being what a lot of people perceive to be an impediment to something that is sort of a USP for your business?
Interesting. Can you explain why you might feel that it would be an impediment?
So I think obviously here we're in a conference that centers a lot on digital health and its development. But I think for a lot of people, from an outsider's point of view, I think it might not be the case where they'll fully sort of accept the idea. Like you've mentioned, some sort of populations might have preconceived notions about technology and digital therapeutics. So yeah, just wanted to get your input on that.
Yeah, I guess it's an interesting question. The problem that we're really trying to solve for here is that we can't get evidence-based mental health care to the people who need them in a timely way, because the current way of doing things is so unscalable. So, our benefit, I guess, of being a remote, to your point, digital first company is that we can provide that scalability and also the high quality care as evidenced in our RCTs and our clinical evidence to organisations like the NHS who may need that extra support with capacity. I totally hear you though, in terms of, there will be some people and organisations which may view digital therapeutics with a bit of a suspicious eye, which is why we have invested so much in evidence, because the RCT is hands down the gold standard way of demonstrating that your product works. And that's why we've got 13 RCTs behind our products, because we want to show that you can do this in a clinically effective way, and that is highly scalable and digital at the same time.
Thank you. We've just got time for one more question. Any other interests? Yeah, just one over here. Thank you.
How do you think about the challenge for DTX, which is creating sustainable revenues? Do you think that more countries follow suit of Scotland, and how long do you think it will take?
Oh, that's a big question. So digital therapeutics is not new. Germany, for example, last year, or I think in 2019, launched their DIGA process. And whilst it's not perfect, it definitely shows that there's appetite at government level, at least in the EU anyway, to adopt digital therapeutics at scale. And similarly, France followed suit, I think, earlier this year, for example, and they were looking to emulate the same kind of model. the fact is, there's a lot of things happening within the NHS. The fact that Scotland has adopted this already means that there are going to be some really exciting conversations ahead in the next couple of years around, what happens within the NHS around digital therapeutics. So I can't give you an exact answer, but I think it's going to be big.
Okay, thank you so much for that. And thank you so much, Charlotte, for sharing your experience and your journey and sharing your success on where we are on an area that really requires a lot of support. We've seen mental health incidents increase during the pandemic. We've seen the inequality of healthcare raised by COVID. And so hopefully your kind of interventions or your kind of products will support many more people going forward. So thank you for all that you've done. And thank you for sharing experience with us here at Giant. Thank you so much.
Thanks for having me.
Round of applause. Thank you. Okay, so I'm just
that drug companies talk about all the time. And it's, what is the mechanism of action? Why does your therapy actually work? A lot of times we're just expected to understand digital therapeutics and just assume that they work, but nobody really talks about the biology, the physiology, the science behind it. And I'm going to do this in the context of a recent study that we did, and I'll share some of the data around that, around migraine. So just a kind of quick introduction about who is Happify. So Happify is the intelligent healing company. What we're focused on is using technology to be more intelligent in healing than we've ever been able to be before without these types of technologies. So we are a clinical grade company that is really ushering in this new era of intelligent healing so that we can use it to heal people across many different conditions, where we start with mental health, but then expand to physical health. And what that means that we combine technology with artificial intelligence, some precision, so that we can actually give you the right therapy at the right time for the right sort of condition that you have, so that it can look at not only large populations of people, but the individual person themselves and give you a very purposeful treatment. We do this across many different types of products. So we have wellness products that have been used by over 4 million people. And those products are provided through employers, health plans, as well as pharma companies. We use AI coaching to deliver up our interventions. We also have communities. We create communities around specific diseases. We have 2 so far. We're launching a few more this next year. We've got one in psoriasis. We have another one in women in midlife. And then we have different sort of medical conditions that we go and treat people in beyond just mental health. So many years ago, when I first started working with Happify, they said, Chris, where should we focus? If we're going to go beyond mental health and address many different conditions, there's lots of diseases out there. Which ones are the priorities for us? So what we initially did is we said, well, you know who's figured out how to make money in healthcare? Pharma companies. Let's see what diseases they focus on. So we looked at the top 25 pharma companies around the world. We looked at over 500 drugs that they had treating people, over 150 diseases that represented $500 billion in revenue. And we said, okay, this is probably a good place to start. What we then did is we looked at our mechanism of action, and we looked at the disease mechanism of action. We looked at where were there some commonalities with regards to comorbid mental health disorders with physical disorders. And we narrowed that down to 57 diseases. We then looked at and created a target product profile. How many patients, what are the levels of severity, what other comorbid conditions do they have? And then from that, we then looked at the market size. We then started to do proof of concept pilots. So we have a therapy that we know is very effective for anxiety and depression. So what we would do is we would recruit patients with a specific disease, give them our therapy for 8 weeks, and see how well we not only help their mental health, but we help their physical health as well. I'm going to talk about one of those today. But we've done about a dozen of these proof of concept pilots, and then we take that data and then use that to design a digital therapy for that specific disease, so that we can, again, go beyond mental health and address symptoms of the disease. We then figure out, what is the business model? Is this going to be a wellness product, a non-prescription digital therapeutic product like a a big health product in Sleepio or Daylight, or is it going to be a prescription digital therapeutic? Each one of those have very different business models. Then we configure it on our platform, and then we commercially launch it. So when we look at a number of different diseases, this is the 57 that I was talking about. We're looking for those diseases that have a high level of comorbidity with mental health. So in these disease areas, about half the patients also have anxiety, depression, or stress as a comorbid condition for these diseases. 60% of these patients are undiagnosed and untreated. So it's a target-rich environment. And what we find from a cost perspective is that patients, so take a diabetic patient. A patient that has diabetes with depression costs 2 to 3 times more than a patient who only has diabetes. So if you can actually treat the depression and anxiety associated with a disease, you can substantially decrease the costs of that patient. So what is the mechanism of action for a digital therapeutic product like ours? The brain is the organ of the body that has the primary role of regulating stressors, okay? And those stressors then cause the body to have certain sort of responses. So you have 4 different body systems here. You have the central nervous system, which is the brain and the spinal cord, but the central nervous system is really regulating these stressors. And these stressors then impact your endocrine system, your immune system, and your autonomic nervous system. And they communicate with one another through neurotransmitters, cytokines, and hormones. And so all of this communication goes on, and when the stressors increase, your body then responds. So when we talk about stressors, people say, well, what is a stressor? How is it different than a stress? So there are physical stressors and there are psychological stressors. The brain responds to stressors the same regardless of whether or not they're physical or psychological. To the brain, stress is stress, okay? So physical stressors can be a lack of physical activity, a lack of sunlight, inadequate sleep, poor diet, nutrition, infections, trauma, autoimmunity disorders, genetic disorders, environmental activities such as pollution, okay? Psychological stressors can occur because of inequality, instability, low social support, excessive choice, low self-esteem, major life events, social and peer comparison or competition, lack of trust, extrinsic goals, or crisis or catastrophes. These both come into the brain, and the brain wants to be, and wants itself as well as the rest of the body to be in homeostasis. That is, everything's fine and everything's working well. The problem when these stressors come up is that there's a stress response, and it requires you to adapt to that response. So the adaptation process is called allostasis. And when you respond well to these types of stressors, then that stressor can actually be positive. We as human beings actually need stressors in our life. It actually what keeps us alive. If we hear a branch break in the middle of the night walking through a forest, we think that it might be a wolf chasing us. So what do? It excites our autonomic nervous system so that we then have more energy to run really fast, outrun the wolf, okay? So stressors keep us alive. The problem with stressors is that when they're chronic and toxic, they happen every day, all day, for days and years at a time, they actually become, you have a maladaptive response, and it's called allostatic load or allostatic wear and tear on the body. And with that sort of load now, it actually creates the conditions that we understand as immune disorders like psoriasis. It creates multiple sclerosis. It creates rheumatoid arthritis, as well as anxiety, depression, and inflammatory disorders like diabetes. And so the lack of a good response to stressors is what then drives these conditions, these diseases that we have. We've actually found ways that we can measure the stress response on our body using biomarkers. These red biomarkers in the cardiovascular system, metabolic, inflammatory, and neuroendocrine systems are the ones that are often used to measure the allostatic response within our body. These black ones are additional biomarkers, but basically there's about 10 biomarkers that we can use to measure the impact that stressors have on our body and the way that we are adapting or not adapting to them. Let me give you 2 examples. One is asthma. So with asthma, the physical and the psychological stressors trigger asthmatic exacerbation. And so these are all sorts of things like a vitamin D deficiency, smoking, violence, lack of family support, obesity. These types of stressors, both physical and psychological, then are regulated by the brain in the way that I just described with allostasis. And then they impact your endocrine system, they impact your respiratory system, and they create an asthmatic exacerbation. Now, when that happens, we have increased levels of stress, anxiety, and depression that we can actually decrease through CBT. These are the digital therapies. So we're decreasing these triggers for an asthmatic event through CBT. We can also decrease them through asthma management, such as an acute RX, an inhaler type product, or a preventative RX product. We have new biologics that are preventative biologics for asthma, and then that improves outcomes. So you see where I put CBT, which is the digital therapy, in this stack. It's at the top. We can actually use these as first-line therapy for asthmatic prevention. The same now is true for migraine. So for migraine, you have lots of different triggers: stress, anxiety, hormones, social factors, metabolism, diet, lack of exercise. Those things then go through the mechanisms of action of the disease. And then we come over to the mechanisms of the management, which again can start with CBT, can be other sorts of management. So when we look at migraine, we see that 1 in 6 Americans, and I'm sure it's probably the same globally, at least in Northern Europe, 1 in 6 people have asthma. 75% of these people are women. This is actually true of most autoimmune disorders. 75% of most of these are women. It's a chronic disease for 4 million people. They cost twice as much, and they've been twice as bad during COVID, and it's comorbid with many other conditions. Patients generally have fairly poor adherence to their existing migraine therapies, and most drugs they do not use very often or very well. It has high levels of depression associated with it, and stress and anxiety, and it costs a lot to treat patients who have migraine. When we look at the different ways that you can actually support patients to manage their migraines, you've got healthcare providers, and you've got the health system. You have pharmaceutical products and medical devices. You have alternative medicine that people use. But then you look at the area of digital therapeutics, and we've got a number of different social support mechanisms that we can use along with digital therapeutics or as part of a digital therapeutic. But we also have lifestyle and self-help with CBT for stress, anxiety, depression, psychoeducation, ICBT for sleep, medication adherence, mindfulness, relaxation, and self-management tools. So when we take all of the drugs that are used to treat a patient with migraine, you have those that are acute therapies, and you have those that are preventative therapies. And you see up in the center there, we have DTX as a preventative therapy for migraines. And this is where we look at, we've mapped this with the frequency of how frequent you get a migraine, as well as the severity. And most of these preventative products are primarily for people that have a high frequency and a fairly high level of severity. And these are the biologics, and they're very expensive drugs. And so a digital therapeutic can be very effective to prevent migraines. So what we did to test all of this, so this is all kind of from the science, and then we said, well, let's actually run a study. And let's use our product for depression and anxiety in this study to see how effective we can be in impacting migraine. So we recruited 5,300 patients in about 4 weeks using our online social media digital recruitment capability, and they then used our product for 4 weeks. We found that the stress was the #1 reported migraine trigger. So this is what we are able to treat, manage, and address with our products, is stress associated with anxiety and depression. So that was the trigger. And as a result of that, we saw a very strong demand for our product among migraine users. We saw 17% improvement with regards to migraine frequency, almost 16% improvement with regards to fatigue associated with migraine, and 12% improvement with migraine pain. So one of the things that always amazes a pharma company when they see the sort of trials that we can do with our product is the richness of the data that we can collect. So, for example, the average pharma company that has a biologic product only has about 15 to 20,000 patients on their drug at any one time. We recruited 5,000 patients in 4 weeks. So we're able to find a lot more patients a lot more quickly that will use our product than they're able to find for their drugs. We then have a lot of rich information around their age, their disease, what other sort of comorbid conditions they have, the frequency and duration of their migraines, the severity triggers. I mentioned stress, anxiety, and depression was the primary trigger for most. Sleep problems was second, and then you have other sort of triggers that they have. We would then look at their baseline migraine as well as their baseline anxiety and depression, so we could see how their migraine changed over time. We then looked at the migraine treatments they had. Most people are just using OTC pain relievers. Only a small percentage are actually using these self-injected preventative products. We then looked at which of our therapeutic tracks they used and they found most effective. And you see primarily it's focused on negative thoughts and then managing stress in uncertain times, which is our COVID track. So then we started to look at some measures. So 71.9% of people reported a noticeable improvement in their quality of life since using our product. So the quality of life measures for migraine improved substantially for most people over that time. We then looked at the improvement in depression and anxiety scores over that time, and we found that the majority of these patients showed improvement in these measures over the course of their therapy. We then looked at the same for anxiety and found a substantial decrease, again, in just 4 weeks of people with regards to their baseline improvement on anxiety. We then looked at the patients and the improvement in their sleep quality, their fatigue. We looked at improvements on those measures, and they were all in the high teens as well. We then looked at their interference, and that is how much does migraine impact your daily life. Found 8% improvement in perceived interference with regards to daily activities and 10% improvement with regards to feelings of frustration or helplessness associated with their migraine. We then also looked at their migraine pain. And what you find with digital therapeutics is they don't necessarily decrease pain, but they increase your ability to manage pain and to actually endure the pain, kind of move through the pain. And so we found substantial improvement in their pain management as well. And so in summary, when we looked at this, we found 18% improvement for those people that did 16 activities. So 16 activities was kind of the minimum dosing required. People who did not do the required 16 activities only showed 3% improvement. So you have a dose effect of 6 times higher. So that helps you kind of understand a placebo effect almost, really, that this was 6 times better than a placebo type of equivalent. You saw that they experienced a lot less frustration and helplessness associated with their disease, their improvement in quality of life, and then their improvement in well-being and anxiety, which is around 25-ish % there. We then take all of this data that we collect from thousands of patients with our product in a specific disease, and we run a design thinking workshop where we bring in patients, we bring in KOLs, we spend time with them asking them questions about their disease, to try to understand how we would modify our product to create something that's more targeted for migraine. And then we think about the business model. How do we want to bring it to market? Will we do it as a wellness product? Will we do it as a non-prescription digital therapeutic? Will we do it as a prescription digital therapeutic? Or could we even do it as a combination product where we combine it with a digital therapy and a drug to treat the patient? And so each one of these then has different regulatory paths. You have wellness products which are not regulated. You have a standalone product which is regulated through different pathways in the US versus Europe. And then you have a combination product, the most difficult regulatory path by far. And then we think about how we would have an end-to-end solution. So would we have a direct consumer product as well as a digital therapeutic to work with it? And then we also think about if we did a combination, what would be the value proposition for a pharma company as well as for us for a combination product? And there we look at the ability to expand the market because you've got now a more comprehensive solution that improves quality of life. We look at the improvement of adherence. The digital therapy can actually drive adherence for the RX product. We look at extending the patent, so you get more patent life, you get better formulary positioning, you have better speed to market, you can increase your market share, you can differentiate your label versus your competitors, and then you have interoperability with all of the data that you collect. So for us, at Happify, this is the way that we think about taking digital therapeutics beyond just the cognitive area into the physical disease arena. Take something that you know that works for mental health and then expand it into physical health domains and take it through all these 8 different steps or processes in order to help you develop the better product or the best product in the market. So with that, I think I have a few minutes left that I could answer any questions that you might have. Yes. If you yell, I can probably hear you.
Which route did you go for?
Which route? We believe that so if I go back here, okay. So we believe that there's a market opportunity for a direct consumer wellness product. We call COPA, it's our disease management platform, where you can provide some sort of free benefit that is going to be part of an ecosystem patient journey approach. And we also think there's an opportunity for a prescription digital therapy product that a physician would give to a patient as well. And we've had 4 different pharma conversations for a combination product. So we think there's 3 different product opportunities here within migraine that we can go after. And we very much believe in this end-to-end ecosystem approach, that we think it's better to have multiple products at different levels of severity, different points to patient journey, that sometimes work with a pharmaceutical and sometimes can work standalone, than just have one product. Yes, in the back?
Probably can't shout that out.
Do you have any escalation features within your product? So for example, if you've got someone in there continuously saying they've got, say, a low mood or key sort of triggers that are quite concerning, is there an escalation that can happen through it?
Yeah, so depending on the product, and I'll give you some examples. So we have in fact, let me go back one more. So with a prescription digital therapeutic, we have a prescription digital therapeutic for major depressive disorder and generalized anxiety disorder. We monitor patients' suicidality or self-harm risk. If we sense, based upon words they use in the therapy, based upon answers they give to the PHQ-9, that they are at high risk, or we also have a panic button that if they feel suicidal, they can hit that button. So if we sense that they are at risk for self-harm, we then have a clinical psychologist that will then intervene and reach out to them, as well as reach out to their physician to try to make sure they're okay. So we have that in that product. Now, there's other escalations when you think about in our disease journey product, okay? We have the ability to have telemedicine as a service. And so if patients want to reach out themselves to a clinician, they can do that through telemedicine. Right now, our product called Ensemble is actually dispensed and prescribed by physicians through telemedicine. And so that telemedicine route is where you're engaging a human. We call this precision care, where you have the digital with the human. And so you can actually get the human support and step up to a higher level of care if you need it. Okay. Yes?
Similar questions what I had for Big Health, Charlotte.
Yeah.
What kind of demographic does your platform serve? And is it global? Like what kind of age group, socioeconomic background, et cetera, Any details you can give us on that?
Yep. So the question was on demographics that we serve. So people will find what I'm going to tell you surprising and counterintuitive, okay? We've done cohort analysis across age cohorts. we find the people that have the highest level of sustained engagement, that is, they download the app, they use the app most often for the longest period of time, are people over the age of 55. Okay? The people that have the lowest level of engagement, sustained engagement, are 18 to 24. Okay? So why is this? Right? Why is it that the older you are, the more engaged you are, and the more likely you are to remain engaged with a product like this? It's because, no offense to all you 18 to 24s, it's because young people have no attention span. They're very impatient. They download apps. They go from app to app to app. The older you get, the more you like consistency. And so if you find a product you like, you will use that product again and again, and you don't go looking for another product. So our month 2 engagement numbers are 64%. 64% of people that download our app are still using it after 2 months. Our 12-month and 24-month is around 35%, 40%, okay, which is very, very high. If you look at the average sustained engagement for mental, or for not mental, but for any health app, it's 2 to 3%. Okay, we're at 60% at 2 months. We're at 40% for a year. So our engagement levels are 20 to 30 times higher than you would see for mental health apps. Now, as far as gender related engagement, and this is a phenomenon just not for our product or for health products digitally, it's for all digital products. It's 70% women, okay? Men just are not as engaged digitally. They don't use social media as much, okay? And also when you look at the disorders that we treat, more women are depressed and anxious than men. More women have MS than men. More women have psoriasis than men. I mean, so as you come down all these autoimmune disorders that have this mechanism of action that I talked about, it's predominantly women, not men. And so it's not surprising that both from a digital perspective, it's mostly women, and from a disease perspective, it's mostly women, okay? From a socioeconomic perspective, a requirement to use digital products, you have to have digital technology, right? And there's lots of conflicting information about digital and socioeconomic levels, okay? On the one hand, people will say, well, poor people can't afford phones, okay? Well, actually, that's not true. There are people that will pay their phone bill before they pay their rent, because they know they're not going to be evicted if they don't pay their rent, but they know they'll be turned off their phone service if they don't pay their bill, right? So what's happened is digital technology has become a requirement for life in the digital age, right? And in fact, it's more required than having a home, right? It's that you're going to pay that bill first. Now, what you do find is a barrier is that the nature of the different digital plans determine what people use. So for example, people that might spend a lot of money to get an iPhone, okay, and might have a plan. I got a minute. That's my last comment, I guess. But anyways, they may not have a plan that allows them unlimited data. So they're not going to use your app if your app sucks up a lot of data. And so you have to think about how they're going to consume digital given their socioeconomic level and what sort of plans they have. All right. Sorry, looks like we're done.
Chris, it's on? Yes, good. Chris, we're kind of running out of time. However, what a super presentation. Wasn't it really good, wasn't it? A round of applause for Chris. Not only for amazing presentation, but also just telling us about his experiences and the success of Happify and all the data, the literature, and the kind of the validation models that have happened. So, Chris, I'd like to thank you again for coming all the way to see us. We'll see you for dinner later, hopefully, and share more thoughts together. Thank you, Chris. All right. Okay, so moving on to our next session. Oh, is that gone?